Good morning. Chair Shelley Bailey, call the Oregon Prescription Drug Affordability Board meeting of March 18th, 2026 to order at approximately 8:03 a.m. Pacific. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Here.
Ann Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman.
Present.
John Murray.
Present.
We have a quorum.
Thank you, Melissa. I would now like to welcome everyone to today's meeting and reference that we do have American Sign Language interpreters with us today. Please use the Zoom controls to access the interpretation channel, and that information is here provided on the screen. So our agenda now begins with the conflict of interest declaration, which are stated each month according to board policies. Do board members have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? And have board members provided testimony to the Oregon legislature about prescription drugs? Mr. Murray, I saw your hand first, so I guess you have the floor and your hand is raised.
Thank you, Chair Bailey. Yes, I have a conflict of interest, a potential conflict of interest, according to the Oregon Ethics Commission, because I have contracts with State of Oregon and PBMs. So, thank you.
Thank you for that declaration. Ms. Hoagland, your hand is raised and I see that you have the floor. The floor is yours.
Just wanted to let folks know that I am promoting our public forums at my clinic site to other providers. That's all.
Okay, thank you, Ms. Hoagland. And I do want to make a comment as well because I did miss the last board meeting. I do want to share for the record that I did provide testimony related to House Bill 4040. I think approximately around February 9th of 2026. And the capacity in which I provided testimony related to was kind of regarding some PDAB language that was originally in House Bill 4040 and how chair was chosen. So again, for the record, I just wanted to reference that I did provide that testimony in February. Mr. Murray, your hand is raised and you have the floor.
Thank you. I apologize. Thank you for the reminder. I tried to provide testimony on similar topic, but was not selected for testimony. So I didn't end up doing that. So thank you.
Okay, thank you very much, Mr. Murray, for that additional information. So we are now moving forward to the discussion related to the draft minutes. So I would like to ask board members if any board members had any corrections to the draft minutes from the February 18th, 2026 meeting. Okay, well, if we have no corrections, then we will go ahead and approve the minutes as presented. So I would now like to call on Sarah Young, PDAB Executive Director, to provide us with a program update. Sarah, welcome, and you have the floor.
Thank you, Chair Bailey, and good morning, members of the board. Plenty to share for February and March, and so I'll try to go through it in order. In the last month, the PDAB team has really been focusing on refining the policy concepts that the board discussed at your February meeting to develop policy options for the board to discuss in today's meeting. We've been styling and finalizing the 2025 drug review report, so we are ready to publish it after you make any last edits and approve the final version. And we have been doing extensive planning for the 2026 drug review process. This includes preparing and testing data analysis code so that we are ready to get to work on the insurance carrier data call and the APAC claims analysis based on the subset of drugs that the board selects for review in 2026. And we have drafted a project timeline through the end of the year. we've outlined our tasks and some of the key milestones that we need to get done for the remainder of 2026. So please, I'd ask the board members to take a close look at the draft timeline in this month's packet and let us know if you have any feedback on it. We've tentatively included a focus on drug reviews for 5 meetings from June to October. And do keep in mind as we're planning this year that the board will need to finalize all of your affordability determinations, ideally by the October meeting, so that we have time to write, review, and approve the 2026 report to the legislature by December. We also drafted a 2-page overview of the PDAB drug review process that is included in this month's packet, and we would really welcome board feedback on whether that is a useful presentation and the accurate information about making it easier for non-technical members of the public to understand your work. We have also been developing online survey-style forms for stakeholder input. In particular, to inform the drug reviews, we welcome input from the specified stakeholders that are called out in our rules. And as a reminder, that includes patients, caregivers, people with scientific or medical training, safety net providers, and payers, plus any other interested Oregonians and consumers who would like to share their feedback with the board. Once the board finalizes the subset list of drugs for this year, we will be posting these feedback forms in late March or early April to the website. Another major focus this month, and it'll be a focus next month too, is planning and promotion of the community forums in April and May. And thank you, Lori, for helping to spread the word about those in your community. We invite everyone at this meeting to attend one of the community forums sponsored by Oregon PDAB. The in-person forums will be held May 5th at the Salem Library, May 6th at the Redmond Library, May 12th at the Asian Health Center in Portland, and May 18th at the Beaverton Library. We also have 3 online forums, and that will be April 28th, May 11th, May 13th. And then, of course, the online board meeting for the month of May will be May 20th, and we especially welcome consumer feedback at that board meeting as well. Of course, the board wants to hear from patients, caregivers, and other Oregonians about the cost of their medications and how medication costs impact their lives. All of those forums will have similar content, so consumers and constituents should choose the best option for your schedule, and we would love to have folks join us. Melissa's got the flyers in English and Spanish displayed on the screen right now, and those are both included in this month's board packet as well as prominently posted to the PDAB website. Please share those around and pass them on to anyone you think might be interested. The forums are free, and Spanish interpretation will be available for the online session, with the May 13th forum prominently featuring Spanish translation. American Sign Language will be available at our May 20th board meeting and may be requested for the other forums. And if you have any other accessibility needs, please reach out to staff so that we can assist you. Thank you to all of the board members who have signed up to attend one or more of the forums. I really appreciate you taking that time to engage with Oregon patients and consumers, and just keep Melissa posted if you have any schedule changes. We have also delivered invitations to the state legislators whose districts are close to the forum, inviting them to attend and also asking for their help to promote the events to their constituents. I also wanted to thank the folks at Caring Ambassadors and the Oregon Office of Rural Health for their time and insights about reaching out to their constituents to invite people to participate in these forums. For everyone else watching the meeting, if you have additional suggestions about how we can reach more Oregon patients and consumers to invite them to participate, I'd like to talk to you. please reach out to us. And continue to share this information with anyone in Oregon that you think may be interested. We will be distributing a press release, advertisements, and social media content about the forums in the coming weeks. And again, please share those things widely as well if you have opportunities to help us spread the word. And of course, if you aren't able to attend one of the forums live, we welcome written feedback at any time. As folks on this meeting know, you can always use the public comment forum on the website to share comments on any topic. And additionally, for the drug reviews, we will have those online survey style forums posted in the next few weeks. So that's a lot of stuff for PDAB. I have a much shorter update on the DPT program. The drug price transparency team has really been focusing on operations and data collection in the last month. This included posting the billing size category list for the 2026 pharmaceutical manufacturer billing cycle and notifying the registered contacts. Manufacturers must request any changes by April 5th based on that list. The team has also been analyzing the new specialty drug and 60-day price increase notices that were received in calendar year 2025 and working on compliance reviews of manufacturer reports, including the first of our reinstated required annual price increase reports. As folks know, the last 6 weeks or so was also the Oregon legislative session. Jesse O'Brien, DFR's own policy manager, will be joining us later in the agenda to share policy updates. But I did want to touch quickly on House Bill 4040, which passed both chambers of the legislature and is awaiting the governor's signature. That bill contains a number of health-related provisions. For the purpose of the PDAB work, we would be impacted by Section 35 of House Bill 4040, which changes the Oregon Revised Statute Section 646A.694 to say that the board may identify at least one insulin product each year. The bill does not change our responsibility as the DCBS staff to produce a full list of insulin drugs each year for the board to consider. It only changes the requirement for the board to say that you may identify at least one insulin product that may create affordability challenges each year based on the criteria in the PDAB rules. Section 35 of House Bill 4040 would take effect immediately on the governor's signature. So we'll continue to monitor the status there. And if it is signed into law, that may impact your decisions in the 2026 affordability reviews around insulin products. Looking ahead, I also wanted to share a brief preview of our upcoming April board meeting. We will actually not have a drug review report to review next month, since we're getting that work done this month. And so since that we have more flexibility in the schedule, I've invited Trevor Douglas and Dee Weston from OHA to come share an update with the board about ArrayRx, the Oregon Prescription Drug Program, and Medicaid drug purchasing in the state. I'd welcome any questions or information requests from board members on those topics, so we can share those questions with Trevor and Dee in advance and make sure that their time with and presentation is as maximally informative to you as possible. And we'll have plenty of time for questions and discussion along with their presentations. If there are other information topics that would be helpful to the board's work or subject matter experts that you would like to hear from, please let me and the team know. We want to facilitate a broad range of resources to inform the board's work, and that certainly includes learning from other experts as well. So with that, are there any questions from board members about all of those updates? Thank you. And with that, Chair Bailey, I'll turn it back to you.
Thank you very much, Sarah. We are now moving to the public comment period for general public comments. The board received 12 letters, which are posted on the board's website. However, I'm going to go ahead and acknowledge those 12 letters here. We have a letter from Erin Callahan from the Diabetes Patient Advocacy Coalition, from Helen Kim Fitzpatrick from AbbVie. We received 2 letters from Ashley Reese, who's a caregiver, from Courtney Piron from Novartis, from Daria McGrew and Alexandria Hussey from Pharma, from Melody Calkins from Biotechnology Innovation Organization Bio, from Rainier Simmons and Jen Lewis from CAN, from Marianne Cooper from Regents Blue Cross Blue Shield of Oregon, from Mary Watcher from Genentech, from Terry Lee and Kristen O'Neill, Merck, from Tiffany Westrick Roberson and Vanessa Lathan from Each and Pick Coalitions, and from Dr. Harry Giwanter from Let My Doctor Decide Action Network. So for the record, those are the 12 letters that we did receive, but I also want to reference that the board did receive 6 requests to speak. I will call on those individuals who have signed up to speak and ask them to state their name and organization. Each speaker will have 3 minutes to speak, and as a reminder, the board will not deliberate on issues or requests during the time. So the first individual here on my list today is Daria McGrew from Pharma. So Daria, if you are here, welcome. You have the floor and you have 3 minutes.
Good morning, Chair, members of the committee. Thank you for the opportunity to speak today. For the record, Daria McGrew on behalf of Pharma. Sorry, pardon me while I arrange windows so I can see the timer. Regarding this month's meeting materials, the staff memo explains that the list of drugs was first narrowed down using established agreed upon criteria, which by my calculations results in 49 drugs. It appears that the list was then shortened, according to the staff memo, further based on individual choices of board members. We respectfully ask that drugs not be chosen for review based on the personal opinions or preferences of individual board members. Instead, selections should be based on clear, consistently applied, and quantitative criteria. Using objective and transparent standards is vital for fair, predictable, and credible decision-making to avoid the risk of arbitrary and capricious decisions. Additionally, I want to understand the new orphan tier designations that were added to the latest version of the dashboard. The definitions for this orphan tier designation sort drugs into tiers depending on how much their utilization and spending related to their orphan indications. This is a rather large conclusion to make without publicly sharing the underlying methodology and data used for calculations, so we ask that much more information be shared on that. Further, we continue to believe this approach conflicts with the board's statute, which categorically exempts orphan designated drugs from affordability review rather than just exempting orphan designated indications of those drugs. For the policy concepts included for discussion today, Pharma is generally supportive of these policy concepts. As we have stated before, patients often pay deductibles or coinsurance based on the list price of medicine, despite PBMs and insurers often actually paying much less for that medication. These rebates are intended to lower drug costs, but patients are often not seeing any reduction if they're in their deductible or phase or coinsurance. Directly sharing rebates savings at the pharmacy would lower out-of-pocket costs directly for patients, align cost sharing with true net prices, and improve adherence, especially for those with ongoing medication needs. I note that while the slides do mention operational complexity of that policy, rebate pass-through at the pharmacy counter is already available as an optional feature from the plans themselves. Many employers are offered an option to select plans that provide rebates directly to patients. Plans and PBMs already have systems in place to share these rebates, and it can be turned on. I'd be happy to share additional information about that with the board. Thank you very much for your time.
Thank you, Ms. McGrew. The next individual on my list today is Primo Castro from Bio. So Primo, if you are here, welcome. You have the floor and you have 3 minutes.
Great, thank you very much. Good morning, Chair and members. My name is Primo Castro with Biotechnology Innovation Organization. Thank you for the opportunity to provide testimony today. Bio represents a diverse range of biotech companies from startups to global biopharmaceutical leaders, all united in the mission to develop medical breakthroughs that improve patients' lives. Bio remains concerned about inaccuracies in the 2026 drug review preliminary list, the continued reliance on WAC and gross drug expenditures as indicators for affordability reviews is misleading as these metrics fail to reflect the net cost to payers or patients. Additionally, the list contained data errors such as incorrect WAC prices and discrepancies in rebate adjusted costs. We urge the board to address these issues to ensure the accuracy and integrity of its reviews. Finally, we reiterate our concerns regarding the inclusion of orphan drugs in the preliminary list, which conflicts with the PDAB statute. Orphan drugs are explicitly exempt from affordability reviews to protect incentives for developing treatments for rare diseases. We strongly encourage the board to uphold the statutory exclusion to support innovation and ensure continued progress in addressing rare diseases. Bio is committed to working collaboratively with the board to ensure that Oregon residents have access to affordable and innovative medicines. Thank you.
Thank you, Primo. The next individual on my list here today is Katie Chandra from Genentech. So Katie, if you are here, welcome, and you have the floor and you have 3 minutes.
Thank you, Chair Bailey and members of the board. I'm Katie Chandra, Head of State Policy for Genentech. Genentech supports pharma's comments that were just made a moment ago, but would like to recognize the work of the board and staff to provide more clarity and transparency regarding orphan drugs. The added level of detail provided in today's meeting materials is critically important to aid in your ongoing decision-making. I would like to draw your attention to Genentech's written comments shared with the board, specifically those submitted in February and again this month, which elaborate on my oral testimony today. Genentech encourages the board to carefully consider the suitability of drugs on the preliminary list for an affordability review. The board should seek to ensure that reviews are based on robust data and lead to meaningful impact for Oregonians. To that end, I want to highlight specific data points related to Genentech's 3 medicines, Ocrevus, Perjeta, and Xolair, and urge the board not to select these drugs for an affordability review. Beginning with Ocrevus, which is a critical disease-modifying therapy and the only FDA-approved option for patients with primary progressive multiple sclerosis, or MS. First, Ocrevus is affordable. In the board's own June 2024 materials, Ocrevus was identified as having the lowest average healthcare spend per enrollee compared to its therapeutic alternatives. Second, Ocrevus delivers value to the system. Ocrevus has historically been and is currently priced approximately 30% lower than the average annual wholesale acquisition cost for other MS medications. Finally, Ocrevus delivers significant state impact. Oregon-specific modeling suggests that improved access to Ocrevus could save the state over $14 million across a 10-year period by reducing long-term disability. Next, Perjeta is a targeted cancer therapy used exclusively in combination with other medicines. As part of varying multi-therapy regimens in metastatic and non-metastatic disease, any review of Perjeta alone would be incomplete and inappropriate and could lead to inaccurate interpretation of costs and affordability at the system and patient level. In addition, current carrier data includes only 89 patients, establishing an extremely small patient sample on which to derive affordability conclusions. Finally, Xolair, although first approved in 2003, research and development has continued, and in 2024, it became the first medicine approved to reduce reactions to food allergies. Xolair review is unnecessary due to shifting market dynamics and data complexities. The board should be aware that an FDA-approved biosimilar was licensed in 2025 and is expected to launch later this year, which will naturally affect costs. In addition, in January, CMS selected Xolair for Medicare maximum fair price negotiation. Furthermore, the board should consider complexities across benefit designs. Xolair is billed both under medical and pharmacy benefits, and historically the APAC database has struggled to aggregate these silos, which may lead to inaccurate conclusions about its affordability. We believe these factors demonstrate that Ocrevus, Perjeta, and Xolair are not suitable candidates for affordability review and urge you not to include them. Thank you.
Thank you, Katie, for providing testimony. Next individual on our list is Lauren Sant from the Caring Ambassadors Program. So Lauren, if you are here, welcome. You have the floor and you have 3 minutes.
Good morning, everyone. My name is Lauren Sant, for the record, Executive Director of the Caring Ambassadors, and we've been empowering people to be ambassadors for their own health since 1997. So I would first off like to thank you for taking my suggestions about the language on the flyer and updating it to encourage people to share what is causing affordability issues for them and at the town halls and listening sessions. And I also would like to thank Sarah and Lou for connecting with Caring Ambassadors to help bring more patients to the events and to understand patient engagement. I am really glad that the annual report recommends capping out-of-pocket costs. The patient community has supported this policy for years, but lawmakers have yet to adopt it. I'm concerned that your recommendation would only apply to drugs identified through affordability reviews. The Each Patient survey showed that a drug's affordability can change over time. And if you change the policy, it should cover all drugs in Oregon, not just those identified in a single review period or with incomplete data. I also want to share again my concern about listing Vraylar as a possible cause of affordability problems. Mental health drugs are treated differently in our system for a reason, and choosing a medication should be made only between a patient and provider. For the upcoming review, when I sorted the spreadsheet using your criteria, the first 4 drugs listed on the sheet are for cancer. As a cancer advocate, this brings me great concern. Like mental health drugs, cancer treatments are highly individualized and should involve shared decision-making between patients and providers only. These therapies are often used with other medications, making the analysis more complex. And how does your data take these factors into account? Any access issues from this review could have serious consequences for those living with cancer, and the financial burden of cancer for patients goes far beyond the cost of a single treatment. And as I mentioned last year, I'm concerned that the drugs selected for review mostly affect people with cancer and chronic diseases, the groups that need the most new treatments. Innovation does have a cost, I recognize that, but a new therapy, if it helps your brain, your liver, your immune system, or eliminates cancer, works better for you and makes you live a more full life. What are the savings for both you and the healthcare system? Please keep that in mind as you go through your reviews. Thank you for all your work, and I look forward to working with you this year to make sure this is happening. I do have a concern that you have way too many drugs on the list for the timeline, and hope that you guys will pare that down to a reasonable amount for the workload that you have and the time that you have to do it. Thanks a lot. Have a great day.
Thank you, Lauren, for being here today. The next individual I have listed on my list here today is Andrew Keepoff from Osberg. So Andrew, if you are here today, welcome. You have the floor and you have 3 minutes.
Thank you. I'm Andrew Kilbach with Osberg. Osberg is a statewide public interest group representing thousands of members across Oregon, and we hear all the time from people around the state who are directly affected by the high cost of prescription drugs, and it's no surprise that cost has caused about 1/3 of people to change their behavior when it comes to their prescribed medication, either by skipping doses or simply not filling a prescription at all. As we said in the last meeting, we think that in order for the board to accomplish its goal of lowering drug costs for consumers, the first place to look should be the list of drugs that are part of the Medicare price negotiation program. These 10 drugs are some of the most widely used and costly drugs in the country. The federal government has already done the hard work of determining a fair price for these drugs. However, only 22% of Americans are covered by Medicare, and we think that any drug that's too expensive for the federal government is too expensive for Oregonians as well. We would like to urge the PDAB to look at recent legislation passed in Virginia that we think is a model for how we should approach our PDAB in Oregon. Virginia House Bill 483 creates a PDAB and directs the newly formed PDAB to first review the list of drugs in the Medicare price negotiation program. The Virginia PDAB is empowered to place upper payment limits on these drugs based on the rates set by the Medicare price negotiation program. This legislation has high potential to lower the cost of prescription drugs in Virginia. Their board has a clear objective: review the drugs that have already been determined to be too expensive by the federal government, and the power to regulate the price of these drugs to meaningfully lower drug costs for consumers. We think that in order for Oregon's board to accomplish its stated mission of lowering drug prices for consumers, this approach should be considered here. The first step for this PDAB would be to designate the next set of drugs to receive affordability reviews to be the 10 drugs that are currently having their prices negotiated by Medicare. This approach has worked in Colorado. Colorado's PDAB, the first in the country to set a UPL, did so for Enbrel at an amount that was specifically based on the Medicare negotiated rate for that drug. It's estimated that Colorado's UPL has the potential to save $32 million per year from drug spending. We urge the board to prioritize drugs under the Medicare price negotiation program. Thank you.
Thank you for being here today. I would now like to welcome Maris Alden or Marianne Cooper from Regents Blue Cross Blue Shield to provide testimony today.
Hi, Chair Bailey, members of the board. My name is Maris Alden. I am a public policy specialist at Regents Blue Cross Blue Shield of Oregon. And on behalf of Regents and our members, we thank the PDAB for the opportunity to comment today. As one of the state's largest health plans, Regents is committed to addressing persistent and emerging needs for the nearly 1 million Oregonians that we serve. At the February meeting, the members discussed recommending an out-of-pocket cost cap policy. We urge the board to reconsider. While this proposal may appear to offer relief, out-of-pocket cost caps don't reduce drug costs. They hide and redistribute them and ultimately increase total healthcare spending for Oregon families and employers. Out-of-pocket caps may sound helpful, but they don't actually make medicine cheaper. They just make it harder to see the real price. Instead of lowering drug costs, these caps shift expenses to other people through higher premiums and out-of-pocket costs. And when patients don't see how much their medications truly cost, drug companies can keep raising their prices without facing pushback. We've already seen this happen with insulin, where prices doubled even though the product didn't change. Another major concern that we have is the point of sale rebate pass-through policy in the meeting materials, which would require patient cost sharing to be calculated using a drug's net price after rebates rather than the list price. Currently, most Oregon health plans use a pass-through model where rebates flow from PBMs to health plans, and we're able to spread savings across the entire member pool to contain premium growth. Point of sale rebates would instead isolate savings to members using rebated drugs, typically brand or specialty products, while increasing premiums and cost sharing for everyone else, since plans can no longer distribute those savings broadly. The 2025 Oregon Drug Price Transparency Report on PBMs shows that 98% of rebates, or roughly $369 million, were passed to plans for member pool cost containment. This policy would instead eliminate that broad distribution, meaning premiums for all members would rise. Nationally, 90% of drug utilization is generic and ineligible for commercial rebates, meaning only that remaining 10% of members who use brand or specialty products would see a benefit, and only until they reach their out-of-pocket maximum. In contrast, the current model provides savings to all members through the entire plan year. Mandating point of sale rebates would superficially lower costs for some, increase costs for the majority, and mask the root cause of unaffordability, manufacturer prices. Both policies reward the wrong actors and fail to fully eliminate the burden of high drug prices on consumers. Manufacturers would retain complete authority to set prices as high as they choose, facing no accountability. Regents is sensitive to the affordability concerns consumers face at the pharmacy counter. However, if unsustainable drug price increases remain unaddressed, the root of the affordability crisis will persist. We urge you to pursue policies that address the real problem, and thank you for your time and consideration.
Thank you for being here today. We now move to the portion of our agenda related to our vote on the final 2025 drug review report with recommendations. So at the February 18th meeting, the board discussed policy recommendations to include in the 2025 report. Today, the board will continue the discussion about policy recommendations and take a vote on the final 2025 drug review report. The report will be delivered to the Oregon legislature. We have included the recommendations and the report in the agenda materials that are posted on the PDAB website. I would now like to call Courtney Whitlock to help walk us through this.
Good morning, Chair Bailey. I just wanted to recognize first that we did have Jesse O'Brien on the agenda to do a policy update. So I wanted to provide him the opportunity before we jump into this.
Yes, thank you very much, Courtney. So for the record, we actually would like to invite Jesse O'Brien, Policy Manager for DFR, to provide us with a program update related to the legislative session. So Jesse, I apologize for reading the wrong piece of the meeting notes for myself, but welcome, and you have the floor.
And Chair Bailey, Jesse is not here yet, so
So my
appreciate
error
you.
would have worked out in our favor.
That's right,
So
exactly.
we will go back to inviting Courtney Whitlock, Senior Policy Analyst, to review everything that I referenced previously about the drug review report with recommendations.
All right, thank you, Chair Bailey, and good morning, board members. I just wanted to say that we have completed, for the most part, the 2025 drug review report that will be submitted to the Oregon legislators by the end of the month. There is one missing component, which is shoring up the policy recommendation section. Before I jump into that, I'm going to share screen and walk through again, kind of the final version of the report. I know it was posted online, but I did want to provide board members any opportunities to discuss any sections of the report before jumping into the policy recommendation. So again, we're able to finalize the format of the reports, including all the drugs that were under review and their narrative. And focusing primarily on this section right here in the next conversation, the recommendations. So before we jump into the next conversation regarding the policy concepts, last month, the board had a discussion to include this provided language, which is targeted cap on out-of-pocket cost for drugs identified through affordability review when not already considered, such as those with insulin. To kind of provide a lot more narrative, staff did research and indicated that there's two possible concepts to consider. And that is what I want to spend some time with the board. The two options either being submitted together, which we would have to change the language in the recommendation on the vote today, or keep this current language and then the report would just be submitted as is. So before I jump over to my next slide deck, does the board have any questions about the final layout or proposal of the report? Yes, Dan, I see your hand up.
Yes. Courtney, I'm just curious, did you use the same format in the last report? Because I thought the format was very good layout this time. It was very easy to read and it was specific and consistent. So I thought those were good format.
Thank you. Yeah, so the kind of the final format of the reports often are associated with two columns. And when it's still in draft form, we'll often have the format still in the full sheets. But then we send it to our communications team and they are the ones that develop the full format. So this is what it will look like. If you go back to last month, I think it wasn't completely structured like this. So this is what it will look like being submitted to the legislators. So with that, I am going to try and stop sharing my screen. I don't know where my device went. I apologize. I have lost my control panel for my screen. How interesting. Oh, there it is. Okay, I'm going to stop sharing. And I have to open a PowerPoint to have this next conversation. So I just need a second to get that up. Okay. So hopefully, board members, you're able to see the screen for the presentation. All right. So two concepts were developed by staff. Staff did submit board members a few memos regarding the more specific details. This PowerPoint is just the high version of that. So concept one would be that patient out-of-pocket cost, which would basically limit the maximum amount of patient pays at the pharmacy counter. The primary objective would be to provide immediate financial protection for patients using high cost medications. The patient cost change would be basically patient liability is capped at a fixed dollar amount per prescription, usually based on a 30-day supply. And then the impact can be that it does not change the price, and it limits the cost sharing, which was previously just discussed in the public comment. I'm going to continue on. I'll come back to point 2 in just a second, but just to round out option 1, again, for the patient out-of-pocket cost, the potential benefit, again, would be a clear and predictable patient cost. So the patient will always know what they're going to be paying for that drug at the counter. And it creates a greater transparency around the net price. Patient concerns would be cost may shift to premiums or plan liability and does not address rebate transparency. So again, public comments already kind of indicated the concerns with doing the patient out-of-pocket cost. So jumping back real quick to the first slide. So the option 2 is the point of sale rebate pass-through. And this would require patient cost sharing to be calculated using the drug's net price after rebates and price concessions rather than the list price, which drugs primarily under co-insurance is charged to patients. The primary objective would be to ensure patient benefits directly from the negotiated rebates and discounts that lower the net price, or it will not go through the carriers. And then the high patient cost change would be that the patient cost saving would vary depending on the negotiated net price of the drug and the plan's benefit design. Again, an impact on the underlying drug price is that it would not impact the drug price, but would align patient cost sharing with the drug net price rather than the list price. So moving on into the second slide for point 2. So the potential benefit would be that immediate financial protection where the patients would directly benefit from negotiated rebates provided by manufacturers, and then align incentives with negotiated discounts. Any patient concerns would be that the patient costs may vary across plans depending on rebate negotiations. Operationally, it is complex as it is an estimated rebate at the point of sale. So before I open it up for a little bit more conversation, I just wanted to provide the board any questions regarding either the memos that were sent or the highlighted concepts here. Okay. Yeah, John, I see your hands up there.
Yeah, thank you, Courtney. Reading through these, I'm highly in favor of both of them, especially in light of the fact that several people have pointed out West Virginia, and I would like time for the PDAB board to look into West Virginia's experience, its real world experience. It's time for changes, and I would like the legislature to have some ammunition for their gun when they go to address these high cost medications. I also appreciate the comment that was made that more of these things need to be applied to, these policies need to be applied to more drugs in Oregon, honestly. Pharmacy was giving as a representative of the pharmacy community, both frontier and rural pharmacies, when policies were enacted that directly affected policy, we were given a clear policy statement to deal with them. And it was just basically deal with it, you know? So I think it's time that other parts of the healthcare or medication delivery system, while I don't recommend deal with it as a policy that was recommended to us, a little more thoughtful approach would be good. This is 2 of them that could be applied, especially with real world experience in other states. So I highly recommend both of these. Thank you.
Thank you, John. I appreciate that. Chris, I see your hand up.
On the next page, Courtney, I just want to make sure I'm understanding in patient out-of-pocket cap, how does that give us greater transparency around net price? Because I mean, it's capping, say we say, hey, for this medication, the max you can pay is $25. Like that's, and then at the pharmacy counter, the patients have to pay $25. So I get it gives the patient clarity about what they're going to have to pay, but I'm not following how it leads to greater transparency around net price.
Yeah, thanks for calling that out, Chris. Actually, I think that should probably be under number 2.
Yeah, it should be in the other
Yeah,
column, right? That's in the wrong spot.
And
Thank you.
And Chris, I mean, to lean into that comment, that's kind of my general concern related to policy concept number 1, is that when we look at kind of going into long session and the budget shortfall at the state, I can't see how a world where policy consideration number 1, it doesn't seem to have, it would seem to have a potential impact on premiums and things. I don't see the cost offset related to patient out-of-pocket cap. But Dr. Hartung, I see your hand is raised, so you have the floor.
Well, I mean, I'm having trouble discerning how both options are going to lead to some sort of premium readjustments, because, you know, the rebates are almost all of them are passed on to health plans. And I mean, they are using that revenue to, adjust, keep premiums as low as they can to attract employers, attract patients who are purchasing on the exchange or whatnot. So they both, you're shifting costs in both arenas. And so I don't see one. Well, so I'm biased because I do think targeted out-of-pocket caps probably have less of an impact on premiums, because if they're targeted, they're not across the board, across the entire pharmacy benefit. So my bias is there. It also provides patients with clarity and predictability in terms of what they're going to be paying for certain drugs versus pass-through rebates. I'm completely open to that kind of concept and that policy recommendation, but I also want to acknowledge that rebates vary greatly by therapeutic class, and some classes don't have as large of a rebate. Some drugs are hardly rebated at all. So you just introduce a lot more variability from the patient experience standpoint in terms of what they might be expecting to pay out of pocket in terms of at the pharmacy counter. I completely acknowledge both policies would likely probably have some sort of effect on premiums, against pooling the risk across a larger population. I think the intent with one, at least, is to, it's focusing on a smaller subset of the population who are taking medications that are very expensive, and they're experiencing a lot of cost at the pharmacy counter. And so but yeah, so that's my general point.
And Mr. Murray, I saw your hand was raised next, so Mr. Murray, you have the floor.
Thank you. Just from a 10,000-foot view, my concern is that it's easy to throw confusion or worry into these two recommendations, but the amount of money that's leaking out of our medication distribution system is in the billions. And so any suggestion that would get movement to reevaluate where those dollars are leaking out of our system is a good thing, in my opinion. I testified, as I've said before at previous meetings, where Oregon plans and PBM sat side by side testifying to legislative committees, suggesting spread pricing is good, it pays our PBM bill, the plans would say. Those kind of statements, those kinds of occurrences in our medication delivery system in Oregon and nationwide is the problem. If we don't start addressing bigger picture issues, and if these help start that conversation, more power to it. If we don't, this PDAB doesn't start looking and getting authorization to study systems that actually are improving affordability for patients, like West Virginia, we will stay stagnated right where we're at. to have no changes to our system in Oregon is ridiculous. And it just puts us further behind. It puts us fewer pharmacies to serve patients that actually look a patient in the eye to help them. It's just, we're going down the wrong road. And if we just start shooting down all these things by including a bunch of weeds in the discussion, we're on the wrong path.
And Mr. Murray, I guess to lean into that, I mean, I am supportive of us, choosing one or both of these recommendations because I do feel it is part of our role and responsibility to educate and inform the legislature. But I suppose leaning into the comment that you just made, Mr. Murray, I did want to briefly just kind of make a comment related to the decisions from the last meeting regarding some of the other policy recommendations. Candidly, I was a little bit disappointed. I was involved in House Bill 2123 all the way back to 2013 when Oregon was one of the first states in the country to recognize PBM practices that materially would impact access and affordability. And it took over a decade to be able to get teeth to that program and have staff at the state of Oregon who could help essentially enforce that. So, I am very supportive of the work that we're doing as a board, but I do believe that we really, Oregon ranks second in the nation. We've said this before related to pharmacy access. That's one pharmacy or 14 pharmacies per every 100,000 Oregonians. We probably all see this ourselves when we go to the pharmacies for those that don't own it. So from my perspective, payer and PBM kind of the piece, even the data that we see presented before us is all kind of represented in part on plan design. So I think that we did very much miss an opportunity to also address, PBM reform. Over 50% of the states have some sort of PBM reform. The federal government now has it for Medicare. So while I'm very supportive of continuing the discussions for these two concepts, and I acknowledge that these were decisions from the previous meeting, I do just for the record want to reference that I do think it was a missed opportunity for us.
Any other comments from?
I mean, I think related to point of sale rebates, at least, Courtney, if you're able to pull up the slide kind of related to that, at least from some of the research I've done, obviously the staff probably has more insight into this, but in addition to West Virginia, I think that Ohio, Kentucky right now is evaluating it through their current legislative session. New York, California, Minnesota, and Massachusetts have some sort of similar, not to say it's the same structure, but something similar. But Mr. Lehman, your hand is raised, so you have the floor.
Yeah, Delaware as well, Chair Bailey. I think there's an article in the New England Journal of Medicine that was published in 2020 where they capped out-of-pocket costs on specialty drugs and around 2016 or so, and they did a research around that was publicized as well. So I think there is some good information out there that we can utilize to sort of model the out-of-pocket caps for the drugs that we have reviewed.
And I saw that, and I think it's at $150. I was actually, for the record, I was speaking about point of sale rebates, but I did come across the same information, Mr. Lehman, that you did. I think, what is it, Delaware, Maryland, and one other state have the caps on some of the specialty. But Dr. Hartung, your hand is raised, so you have the floor.
Oh, I was just going to mention that the recent FTC Express Scripts settlement also has that as a provision of that settlement, that out-of-pocket costs are going to be directly linked to net prices.
All right. Well, I appreciate the conversation. I guess it comes back to decision of what the board would like to do. If they want to keep the current language that's in the report with just the cap language, or if the board would like to also include language around the point of sale rebate.
Courtney, do you have suggested language that and I'm not trying to shorten the discussion related to this topic by any stretch, but do you have suggested language that we might be able to look at that potentially would be included in the report if it was the will of the board to include that?
Yeah. Are you able to see my screen with the Word document in it? Okay.
Yes.
So
we
I
can-
worked on this morning. So again, it's I kind of predicted that this was going to come down. I was like, if we're going to change the language in the report, might as well provide something. So just as from a policy perspective, providing legislators with an outline. I sent out late yesterday kind of a memo combining the two options to board members to review for today's meeting. And if the board want, we can include that as an appendix A, or I can remove that statement and just put the policy options 1 and 2, and then have legislators provide guidance to the board about what concept may be most beneficial for their constituents and how the board can work with addressing the costs and affordability. Yeah, Dr. Hartung, I see your hand up.
My question is the scope for, I guess, policy option, well, for both of them maybe. You know, I think the intent of the board at the last meeting was because these recommendations are attached to our affordability review conclusions. And so I feel like the thrust of the document are directed at those 4 or 5 drugs that we identified, and that I think that the intent was that the out-of-pocket caps, you know, this is a legislative option that the legislator could consider for drugs that we think may present affordability concerns for patients. I also recognize that like some of our deliberations were about affordability issues for the health system and maybe less an issue for the patient. But nevertheless, you know, so that was the point of number 1 from my recollection of the conversation. 2, the rebate, the pass-through rebates, is that specific to the drugs that we have that we're identifying, or is that just like a recommendation overall across for the entire system?
So when the concepts were developed, it was based off of this language here. So target caps on patient out-of-pocket cost for drugs identified through the affordability review. So pass-through and cap would have been associated via this language, which is identified for the drug under review. Now, again, this is an opportunity for the board to let staff know if this language should be updated before we submit it to the legislators. So I was just going off
I guess with updating the language, Dr. Hartung, at least from what I believe you're inferring, is just making sure that language, the suggested language is being presented here, is in alignment with saying that it was for the drugs, or at least if I'm hearing you right, you thought option 1 would be related to drugs that had been identified by the PDAB as potentially having affordability issues. Is it your thought that then option 2 would also be pertaining specifically to drugs that may be identified as creating affordability issues? So I guess it doesn't specifically say it in this language, right?
Well, that was my question is, if we chose to include some element of option 2, would it be equally as focused?
Yeah.
I would think that would be the intention, but I can see how you're referencing that it's not specifically stated.
I mean, we can do what we like. I just want to focus on figuring out what the board wants to do.
And Ms. Hoagland, your hand is raised. You have the floor.
Yeah, my understanding was that these were ideas for our identified medications. Ideally, we would like to extend them beyond that, but it was kind of in the discussion of what are we going to do about recognizing that these are expensive medicines, what kinds of policies would change that, and maybe more in the sense of an experiment and a small scale to see how it goes with the recommendations of other mechanisms to reduce pharmacy costs with PBMs, et cetera. That was kind of my understanding of it. And maybe that's what I'm recommending should be more clearly stated.
And Ms. Coder, your hand is raised. You have the floor.
Thank you, Chair Bailey. I agree with limiting the scope of the recommendations to the drugs that were selected as presenting affordability challenges. I do have a question about policy option 2 as it is written here. In the second sentence, it says a portion of the rebate would be passed through. I think the West Virginia statute was 100% passed through. And so I want to clarify the intent here.
Yeah, no, it would be the rebate would be passed through.
Okay.
And one thing I would add related to, I know we've referenced West Virginia, so I've kind of went and looked at Kansas and some other states that are looking at it. I guess I do want to mention leaning into how does that impact the patient directly. It looks like the way some of these pass-through models are built is that the patient out of pocket essentially is based on the lower net, right? So it's, you know, applied once. Their out of pocket is directly linked to what the net of the rebate is. Now, I would not disagree with Vice Chair Dr. Hartung's comment that that doesn't necessarily always, you know, mean that that would 100% of the time for those drugs result in, you know, a significantly modified out of pocket to the patient, but I think they separate it where they separate pharmacy reimbursement and the calculated patient out of pocket based on the net. But that's just my understanding of how those programs work. Mr. Murray, you have the floor.
Thank you. I appreciate the clarifications, and I do support restricting it to the medications that were identified as affordability challenges. I was interested to hear in the public comment the possibility, and I'd like to hear more about it in future meetings possibly, of the availability of rebate information to plans and PBMs. If it's that readily available from the manufacturers, it would not make this as difficult a situation to implement. And so I am supportive of this, of including these in the reports.
Mr. Murray, some additional research I did on that topic. I think what their brass tacks, what they kind of do is they do an estimated load on the back end for claims adjudication of the anticipated rebate based on what their contracts are for rebates. So it's really based on the estimate. Now, getting that visibility to other constituents and stakeholders obviously is different, but on the claims adjudication side, I do think they are estimating, and then any delta on that does go back to the plan if the estimate is different than the actual. But from an operational perspective, I think that's at least how some of the states that are doing it have operationalized it.
Well, I guess I would make a motion then to include the policy option 1 and 2 verbiage that is on the screen right now in the annual report, the report that we're putting forth now.
Thank you for that motion, Mr. Murray. I did see Mr. Kennedy's hand go up kind of mid-motion. So, Mr. Kennedy, you have the floor.
Yes, I would second John's recommendation as amended, and both options available.
And I hear that we have a motion and a second, but I do want to recognize Mr. Lehman. So, Mr. Lehman, your hand was raised. You have the floor.
I was just going to ask if we could do them both separately. So that instead of voting on both of them, we could vote individually, so that maybe there are board members who support one but not both options. We could have the opportunity to speak to each one or vote on each one separately.
Yeah, I would accept that amendment. Yeah, that's fine.
Vice Chair Dr. Hartung, your hand is raised. You have the floor.
I like what Board Member Lehman suggested. One other, well, so I'll just say I was just kind of typing out some potential text. We could present something to the, this is a recommendation to the legislature, so it's basically like, here's something you can chew on and potentially legislate on, but we could frame it in terms of targeted limits on out-of-pocket costs for drugs identified through the affordability review. Out-of-pocket limits could be achieved through, and then present the options, out-of-pocket caps or pass-through rebates. And so giving legislators kind of the options of like, here are some, different examples of ways that could reduce out-of-pocket costs if people want to present both options as a way to limit.
And that's
max.
the whole intention of presenting both options, is that the legislators would have the extra information to consider. Did you want some of that language that you mentioned changed in the initial narrative, like what I have, to make it more clear that that is what there are two different options that can be considered into the report. And again, the legislators will take this and they will apply it to the bills that they feel is suitable, if they feel either one is reasonable to do, or if they're both reasonable to put through. It's up to them, or they can provide us additional guidance, provide the board additional guidance on if these would work or not.
I guess I'm fine with what is written there.
But I'm hearing what you say, though, Vice Chair Dr. Hartung, that the second sentence maybe makes them feel like they're a little more counter to each other than is likely the net impact, right? I think you were basically referencing that here's a couple approaches and lenses that you may be able to look at improving affordability on these drugs that may or may not create potential affordability challenges. Here's two different ways to think about it.
Yeah, you could say the board evaluated two policy options designed to address prescription drug affordability, like for the patient.
Could we simply remove the second sentence so that we don't create confusion?
Yeah. Yeah, so how about this? The board evaluated two policy options designed to address prescription drug affordability identified through the PDAB affordability review process. Both our options aim to limit out-of-pocket costs for drugs identified through the affordability review period. And then you can lay out the options.
What was that last part about aim to limit out-of-pocket costs?
Both options aim to limit out-of-pocket costs for the patient, or something like that.
So we have patient up above in here. So we have that affordable for the patient identified through. So you want me to remove this identifier?
Yeah. To remove it there. For patients, yeah.
Michelle, while Courtney's making that edit, your hand is raised, so you have the floor.
Thank you. Instead of patients, do we want to say Oregonians?
I think that's reasonable because, it impacts households, it impacts, more than just the specific patient taking the medication. So I think that's an improved edit.
All right. So for members, did you want to attach an appendix A from the memo sent for your reference, or I can just take that out and
Courtney, for the record, is the appendix A essentially the potential proposed policy memorandums that you worked on based on the feedback that we all provided during the last meeting? Or
Yeah.
everyone except?
Yeah, so I
absent?
sent one last night that has the combination of both of
Yep.
them.
That's okay. I thought that was what you were referencing related to the appendix. From my perspective, if I was a legislator, I would want an appendix to read more into what the heck we're talking about here, but that's just my opinion.
Yeah, I'm gonna have to post them anyway online since it's part of the conversation and decision making today, but since I sent it out late last night for review for today's conversation, I do have it up just for transparency. A document sent yesterday outlining the purpose of the two options, the policy context of them, how which one lines out more detail for each option for consideration for the legislators, potential guardrails, other concepts that were evaluated. So it's basically the same information that was presented when they were separated. Yes, John.
Where are we at procedurally? I have a motion on the floor, but I'm open to withdrawing it and restating it. If that would be more easily handled with considerations.
Well, we do have a motion on the floor, but we since the motion, we have worked on developing language that would potentially include both. So if you need to withdraw so that board members can vote separately on each one, that is where we need to remove it. But if board members are inclined to provide both to the legislators for review based off of the language edited here, then we can keep the motion.
I guess
and I see Melissa.
I recognize also that Melissa raised her hand, so she may have some additional information for us.
I do have a motion I could share on the screen based on this conversation. If that would help.
Yeah, when we get there, we'll throw the full motion up. We need to decide if we're going to separate each option into a vote, or if we're going to vote under each one separately. Yes, Chris, I see your
Yeah,
hand.
Courtney and John, I think with the new wording, your original motion is probably fine. I don't think there's a way we could vote on this wording separately. So that's probably, I withdraw sort of my comment earlier.
Thank you, Chris. I didn't want to leave anyone out of the conversation or make it difficult. So I will leave my motion as stated then, please. Thank you, with the amended language as it is now.
Vice Chair Dr. Hartung, your hand is raised. You have the floor.
I'm sorry. I missed this. Are we voting on each one separately or now just together again because of what we just wordsmithed?
Yeah.
So I still think we should vote. I still think we should vote on them separately, and then we can tweak the intro language a little bit because board members may have different perspectives on these things that we need to kind of figure out where people stand on them.
I don't disagree with Vice Chair Dr. Hartung. I mean, can we, if we have the will to have a motion in a second, can we vote on policy option number 1 and policy option number 2 separately? And then based on the outcome of those votes, wordsmith the preliminary paragraph if necessary. Could we do that?
Yes. And depending on what one goes through, we'd still keep the original language in the report, probably just provide some extended information here. And then probably have to remove this because the policy memo is a combination of the two. So that would be the only change. But I can add this into the report under that recommendation section, or if it's policy 2 that goes through, then it'd be that would just go into the report. Otherwise, if it's together, then it would be showing as is. So let me lean into Melissa for a second. Melissa, I know you're asking to split. Are you able to provide slides real quick to show a vote for policy option 1, stating patient out-of-pocket cost cap model, And then vote number 2, policy option 2, point of sale rebate pass-through model.
Yes, I have those slides prepared now.
Perfect. All right, I will stop sharing so we will need the motion removed.
I'll withdraw the motion then and
Thank you, John.
restate it. You're welcome to motion to approve the 2025 drug review report with policy 1, patient out-of-pocket cost cap model as discussed by the board today.
Do you have a second? Laura, I see your hand up.
I second the motion.
Thank you. So John first, Lori second. Melissa, will you please call roll?
Lori Hoagland,
Yes.
Dan Kennedy,
No.
Michelle Coder,
No.
Chris Lehman,
Yes.
John Murray,
Yes.
Vice Chair Dan Hartung,
Yes.
Chair Shelley Bailey.
Yes.
The vote is 5-2, and the motion passes.
Thank you, Melissa.
Could I-
For
Yeah,
policy 2.
language
Yep,
policy 2, please?
there it is.
Thank you. Motion, I would move to approve the 2025 drug review report with policy 2, point of sale rebate pass-through model as discussed by the board today.
Is there a second? Lori.
I'll second the motion.
Thank you, Lori. John first made the motion. Lori second motion. Melissa, can you please call roll?
Lori Hoagland,
Yes.
Dan Kennedy,
No.
Michelle Coder,
Yes.
Chris Lehman,
No.
John Murray,
Yes.
Vice Chair Dan Hartung,
No.
Chair Shelley Bailey.
Yes.
The vote is 4-3, and the motion passes.
Thank you, Melissa. So based off of the voting, it looks like both policy options will be presented into the final 2025 affordability review reports as outlined here with edits. Alrighty, Dr. Hartung, I see your hand up.
Are we still including that language about Appendix A or whatever that has some of the more details?
Yes.
Can we throw that up on the screen? I just want to make a suggestion in terms of a piece of language.
Go for it. I'll make it larger here. What page or?
Page 1, or no, page 2. Page 2.
Okay.
That like summary table.
Maybe down here.
Uh,
I'm not seeing what you're.
Melissa, could you
Oh,
stop screen
sorry.
sharing so Courtney can take over?
Sorry about that. Let me get my. All right, are you able to see my screen?
Yeah.
Yes.
So yes. So the table 1. So generally, the language in the appendix, I think, or in the entire document is, in my opinion, is good. This table, I feel like there's a tilt to it in terms of the, out-of-pocket cost, shift cost of premiums, point of sale rebate pass through, reduces rebate revenue to plans. I feel, I feel like there's a tilt towards the point of sale rebates that, reducing revenue to plans, the ultimate consequence of that would be also an adjustment on premiums, I feel. So, I mean, my suggestion is to kind of have the same kind of language, that they both potentially are going to lead to some sort of adjustment of premiums. Like you have the language throughout is good and balanced. So maybe just adapting some of the other language that you have further on, like, let's see here. Just flagged it. May lead to some premium adjustments or change in benefit designs across the broader insurance risk pool. So maybe for both, both sections, you could just have, I think the same concerns are there that, it could lead to premium adjustments.
I mean, is it potential that we just remove the table entirely? Because at least my understanding with point of sale rebates is that delta that would otherwise have went to the plan is actually, going to the patient savings piece so that it actually is zero sum. And so I hear what you're saying, Vice Chair Dr. Hartung, that we don't want to, bias one way or the other, but would it be appropriate then for, I know we already voted on, well, we didn't vote on the appendix, but maybe remove table 1?
At the will of the board. I mean, I'm happy to remove it if the rest of the narrative of the memo fits the need.
Yeah, I think
Yeah,
that,
okay.
this is John, I think deleting table 1, the narrative is a good idea. I think the narrative explains it well enough.
Okay.
Okay.
Benefits and the detriments.
All right. Well, that was easy enough. Yeah, so the memo concept will be sent to it as an appendix in the report then as well.
Ms. Holt, I see your hand is raised. I want to make sure you have the floor.
I was just going to reinforce that thinking because I think the table simplifies unintended consequences. And so therefore, I think it's good to not have.
Chris, I see.
Courtney, could we look one more time at the final wording that you had in that kind of intro paragraph? I didn't read it as close because I thought we had said we were going to come back and maybe wordsmith depending on how the vote went, but not in the appendix, but in the actual, yeah. Could you just read it exact? So it's the
Yeah, let me just simplify this for a second. So this would be the submitted language. It says the board evaluated 2 policy options designed to address prescription drug affordability identified through the PDAB affordability review process. Both are options aimed to limit out-of-pocket costs for Oregonians as presented to the legislators for consideration. Additional detail on each option is provided in Appendix A. Policy option 1, patient out-of-pocket cost cap model. So this policy option 1 is designed to limit patient cost exposure by establishing maximum cost sharing thresholds for identified prescription drugs. Under this approach, patients would not pay more than a defined cap per prescription or per month, regardless of underlying list price, benefit design, or deductible status. The intent is to provide predictable, stable cost sharing for high cost drugs identified through the PDAB affordability reviews. And policy option 2 is a point of sale rebate pass-through model. This model, option 2, is designed to directly reduce patient out-of-pocket costs by applying manufacturer rebate at the point of sale. Instead of rebates being retained within the system and reflected only in net cost to insurers, the rebate would be passed through to patients at the pharmacy counter. This approach lowers the patient's immediate cost burden and aligns the price paid at the point of sale more closely than drugs net cost.
Courtney, maybe under policy option 2, we should clarify just that this approach may lower patient immediate cost burden. Just trying to hear what Vice Chair Dr. Hartung was saying that sorry, last sentence.
Okay.
I mean, maybe there too, but last sentence. This approach may lower.
And also you need to say a line instead of a lines, just to keep the grammar on track. In the next to last next to the last line there.
So there was something up here that I saw. I know we already stated it in the introduction, but I also was put add it here. So, okay.
Maybe, do you want to put the high-cost drugs identified through PDAB affordability reviews at the very end of the last sentence in paragraph 2 as well, Courtney? Just copying it from the end of policy 1.
So that's the intent. Is that what you're asking? Because I just indicated it here as far as
Oh, yeah.
identified through the.
Let's see. For that wording, you need to have reduce patient out-of-pocket costs for drugs identified through.
Thank you, Sarah.
Does that edited language work for the board members?
Clarifies that it's for the drugs identified through the PDAB review process. And then this again, as edited will go into the report. We have not voted on the report. You still have to vote on the report with the edits of this here. So is the board ready to vote to send the letter or send the report to the legislators with the current edits under the recommendation section? Laura, I see your hand up.
This may be a little bit petty, but between the two options, one lists it as the identified prescription drugs and the other one as the high cost. It might be best to stable cost sharing for identified through the affordability process, so that they're the same. That's all.
Where are you seeing the?
So you say the intent is to provide predictable, stable cost sharing for high cost drugs identified. You say that in the policy option 1, and then in the policy option 2, you say basically it's designed, the intent is for drugs identified through PDAB affordability reviews. I'm not sure that, I think we could skip the high cost and just do the identified through.
Gotcha. Okay. Dan, I see your hand up. Did you have anything else to add to
Yes. I just wanted to state for the record that I am in favor of option 1 and option 2. Although I voted no on both of those, my thought was that we were going to have a third vote combining both option 1 and option 2. So I'm in favor of both of those combinations being sent forward. And my mistake, I just wanted to clarify that.
Thanks, Dan. I appreciate the clarity.
You got your
All right.
wish.
I know. It worked out. Yeah.
Awesome. Thank you. So now that both options are going forward, we have finessed the language to go into the recommendation section. Is the board ready to vote to submit the final report or the 2025 review to the legislators? If so, I can stop sharing screen and Melissa can share the motion and one of the board members can.
I see 2 hands raised. Or Mr. Murray, I guess your hand is raised first, so you have the floor.
Oh, you're on mute. And Melissa, do you have the motion to share on screen, please? Oh, there it is.
Thank you, Melissa.
Okay.
I would motion to approve the 2025 drug review report with policy 1 and policy 2 to send to the Oregon legislature as discussed by the board today.
Thank you, John. Is there a second on the floor?
I will second. Oh,
Thank you, Mr. Kennedy. John first. Dan Kennedy second. Melissa, would you please call roll?
Lori Hoagland,
Yes.
Dan Kennedy,
yes.
Michelle Coder,
Yes.
Chris Lehman,
Yes.
John Murray,
Yes.
Vice Chair Dan Hartung,
Yes.
Chair Shelley Bailey.
Yes.
The vote is 7-0. The motion passes.
Thank you, Melissa.
Back to you, Chair Bailey. Thank you so much, board members. Appreciate your hard work and dedication to this work that we've done. And congratulations on your first report for the affordability reviews.
Thank you very much, Courtney, and thank you for the efforts extended by the entire team to support us in these endeavors. I'm now going to go back to actually following the agenda as it was presented to me and invite Jesse O'Brien, Policy Manager at DFR, to provide us with an update on the legislative session. So Jesse, my apologies for my initial error, but welcome and you have the floor.
Great. Good morning, Chair Bailey and members of the board. As noted, I'm Jesse O'Brien. I'm the policy manager with the Division of Financial Regulation, and our team does everything legislative for the division, which includes tracking things on behalf of the board, although, of course, the board is somewhat independent from the division. But could we move to the next slide, please? Okay, so many of you are, I'm sure, quite aware of this, but during even-numbered years, Oregon has a short legislative session that is no longer than 35 days. During odd-numbered years, there's a session that's more on the order of 6 months. So this year's session just ended pretty recently here, opened February 2nd and ended March 6th, which was a couple of days early, but pretty close to the constitutional length. Agencies like DCBS and DFR don't typically have the ability to introduce our own legislation during the short sessions. Typically, the governor will introduce a small number of bills on behalf of agencies during long sessions, but not short sessions. But we do monitor legislative activity in the various areas affecting the agency, and we're often called on to weigh in, provide information. Every once in a while, we'll actually take positions on legislation if they're particularly high priority for the agency. There's some stats here on the session as a whole. 304 bills were introduced. 104 of those were bills that we were tracking at the division, so they related in one way or another to one of our issue areas. That's a pretty large percentage, as you'll see, but not all of those bills necessarily had a super strong connection to our work. They just might have to do with healthcare in general, or something having to do with finance that doesn't really directly affect us. And then out of those bills, 50 wind up passing and are headed toward becoming law. So if we could move to the next slide, please. So these are some of the key prescription drug related pieces of legislation that we were watching. I would say this short session, there was maybe less of a focus on prescription drug issues than there has been sometimes in the past. And there were certain issues where there weren't really any significant legislative movements. So for example, every session for the past several years, there's been some kind of pharmacy benefit manager legislation introduced, and that really didn't happen this time around. I would be surprised if that didn't happen next year, but it hasn't happened this year. And there's only a pretty limited number of things that wound up passing related to prescription drugs. But one bill that wound up being a vehicle for a large number of different policy proposals was House Bill 4040, which is a kind of omnibus bill covering all kinds of different health policy issues that came out of the House Healthcare Committee. And there's a few pieces there that relate to prescription drugs. So there were a couple of elements to that bill that actually related directly to the board's work. The one that wound up in the version of the bill that passed makes a small change to the insulin review requirements in the statute for the board. As you all will recall, and probably you've spoken about this before, and this legislation before, there has been a statutory requirement to review at least one insulin product as part of the annual affordability reviews, and some stakeholders thought that that should really be more of a discretionary choice by the board rather than something that had to be done every single year. I think in part due to the conversations looking at the affordability reviews for the past year, that it was a little difficult to figure out how to handle the insulin requirement. So basically, the change is pretty simple and makes it so that the board can decide to review an insulin product, but is not required to do so. There's also a pretty wonky change in that legislation related to licensure requirements for PSAOs, or Pharmaceutical Services Administrative Organizations. Probably this audience is familiar with who those are, but those are entities that work with community pharmacies to negotiate on their behalf with pharmacy benefit managers. And there was a bill passed last year that I think it was last year that created licensure or clarified licensure requirements for those entities with DCBS, but there was what seemed to be a drafting error with that. So this legislation fixed that. It does have pretty broad exemptions, such that I think a lot of the PSAOs still will not actually have to be licensed with us, but that's where that's at. And then another concept that was included in here was creating a new process for what's called the Legislative Policy and Research Office, or LPRO, which is an arm of the legislature to do reviews of proposed health benefit mandates. So that could include things like the kind of perennial proposal to require health plans to cover fertility treatments, but it could apply to prescription drug coverage requirements as well, which is why I wanted to include it here. So basically, there will be a kind of limited opportunity for legislators to have the LPRO staff do a review of the potential impact of a proposed health benefit mandate, and then also noteworthy, I thought the original version of House Bill 4040, as it was introduced, also included a proposal to change the selection process for the chair of the board, to make that a direct appointment by the governor, but that wound up getting amended out of the bill. The agency wasn't deeply involved in those discussions, so I'm not totally sure what happened there. Ultimately, that is something that the agency wouldn't have a strong opinion about one way or the other. We'll just do whatever the legislature wants us to do. So that's that bill. And then House Bill 4131 is another significant prescription drug bill. It doesn't really have that big of a connection to the board, but creates a new opportunity for mobile pharmacies to have their own kind of licensure. And then definitely relevant to the board, but unfortunately did not pass, was Senate Bill 1528, which the division supported, which would have expanded the drug price transparency program, reporting requirements around drug manufacturer-funded patient assistance programs. some of you will be familiar with this, but currently the DPT program receives reports for patient assistance programs when they are associated with a drug that files an annual price increase report with the program, but that's only for drugs that have a price increase above specified threshold. And there are a lot of drugs that have these programs that do not meet that threshold. Even if they have a high price, they might just not have a big price increase, so they don't hit that threshold. And so the proposal, which has been something that the division and the program have been advocating for a long time, has been to just make that a broader reporting requirement for all patient assistance programs so that more information could be provided about how those programs are affecting access and costs in the state. And the proposal did pass the Senate this time, but did not ultimately advance in the House. The proponents of that legislation will be likely working on it again next year. And then the last bill I thought I'd mention is Senate Bill 1598, which has to do with coverage of immunizations and vaccines and preventative services. And this was introduced and supported by DCBS and OHA as a kind of response to the federal changes regarding the vaccine recommendations of the I'm forgetting what ACIP stands for, but the Advisory Committee on Immunization Practices, that's what it is, which is an advisory body to the CDC. I'm sure many of you are aware that there have been some changes to that body under the new administration, and they've been scaling back recommendations for vaccine administration, and those changes also have downstream effects for what health insurance plans and Medicaid and so forth is required to cover. So what the bill does is it basically gives the Oregon health policy director, OHA's health policy director, the ability to, or not health policy director, sorry, public health director, the ability to make recommendations for coverage of immunizations and vaccines on an ongoing basis to kind of backfill anything that is removed from the federal recommendations, and to preserve access. And it also updates the preventative services requirement in Oregon law, which we have to periodically update because it doesn't automatically update. So it's updated now to a date in 2025, and that's a separate set of federal recommendations that so far has not been whittled back, aside from the immunizations, but is something that the agencies wanted to update. So that was all the bills I wanted to cover. We can go to the next slide, which is just asking if anyone has any questions.
Mr. Lehman, your hand is raised. You have the floor.
Yeah, I just want to thank the director for inviting Jesse. And Jesse, thank you for your time for coming today. I appreciate these updates. It's good for us as a board to stay up to date with what's going on. So I appreciate you taking the time out of your busy schedule to share this information with us.
Of course, anytime. And I've been in conversation with Sarah about trying to have a more regular cadence of DFR policy updates to the board, which we're happy to do. So we're working on figuring out how that'll work going forward.
And Chris, to lean into that comment, I have had discussions about kind of what is the process during a short session and the long session to inform board members a little bit more in real time, whether that's the full board or board leadership, on different policy related, initiatives that may be being evaluated, so that board members kind of are aware of it, especially if something, might be of importance to board members, between board meetings. So that's been a, ongoing discussion we're working through providing more of a process for. So Sarah, your hand is raised, and You have the floor.
Thank you, Chair Bailey, and thanks for your comments, Mr. Lehman. I'm glad that this was helpful, and please, I would ask all of the board members to continue providing feedback to me and staff about, again, what kinds of content it's helpful for us to bring to the board meetings to inform your work. And, you know, Jesse's updates are going to be different focus and possibly a different cadence outside of session versus inside of session, just because of the realities of how much more things are going on with the legislature at different times in the year. So please keep letting us know how this is working for you, and if there's any other information resources that we can bring to the board as staff to help inform your work. And thank you, Jesse. Definitely appreciate your time.
Perfect. Well, thank you, Sarah. I do want to announce for everyone here today that we do have a scheduled 5-minute break around 10:30 a.m. Pacific. So I just wanted everyone to plan for that before we move to the next portion of our agenda, which is the board will continue the 2026 drug review. In January, staff presented a preliminary list of prescription drugs and insulin products for the 2026 drug reviews based on commercial insurer reporting from calendar year 2024. The board discussed the revised the list during the January and February meetings. Today, the board will vote to select a subset list of prescription drugs and insulin to prioritize for review under OAR 925-200-0010. Drug review information is included in today's agenda materials and is posted on the PDAB website. Courtney will begin our discussion. So Courtney Whitlock, Senior Policy Analyst, welcome, and you have the floor.
All right. Thank you, Chair Bailey. And hello again, board members. Before we jump into the whole conversation about drilling down the subset list, I wanted to just do a quick level set of our process. I don't know why that just jumped like that. Apologies. Let me try that again. Alrighty. So hopefully everybody's kind of gotten to the familiarity that I like to show the roadmap at each board meeting so that it kind of just level sets where we're at in our review process. So again, congratulations. We submitted the vote for the final approval. So a big check mark on of that for the month. This month, or for this board meeting, we will have a conversation around identifying a subset list of drugs to submit to carriers through a data call process. And that will also include insulin products. And then while we're in this process of waiting for information to be submitted back to staff through the data call, staff will be also doing outreach to collect additional information from consumers, patients, advocacy groups, pharma, bio, whoever can provide us additional information on the subset list so we can create the material packets for the review starting. We're hoping to start the review process in June, but there may be, you know, it may realistically start in July. It depends on how much information we get and then how it's going to be analyzed, but it is the goal to start in June. Just know there might be a slight caveat to start in July. But as Sarah had mentioned earlier, we really need to make sure that we have some sort of direction or sound guidance from board member by October when we start developing the report for the end of year to be submitted, because we will not have an opportunity to have an extension like we did into this review cycle. So, and then again, board will review the draft report at the end of the year and submit it by the end of the year. And then probably starting in December next year, I will reintroduce the next preliminary list. So it's a constant vicious cycle, very fast moving, but hopefully as we've kind of shored up our review processes, this will become a little bit easier to identify drugs and get through the process. And just kind of to level set, so this was added into the material packet to help kind of show on a high level what the review process is and how we get to where we're at. So right now we're at, step one here, the drug identification. This is under our OAR 925-200-0010 rule. So we're going to look at that large preliminary list. I know we had discussions last month where board members provided staff with their concepts of drugs that they would like to have considered for review. We'll have that conversation here in a few moments. But really looking at getting those drugs identified. Step two is that data information to extend that collection to the patients and stakeholders and start collaborating on how we're going to set that data, that information up into the material packets. That leads to step three, which is the drug reviews under the ORS and OAR that govern the work that the board does. Then through those reviews, the board creates those recommendations, and then the review and the recommendations are associated into the annual report. So this is the picture of it. The next slide is the verbal outline. So before I jump over, is there anything regarding the timeline or the roadmap that board members wanted to take an opportunity to discuss? Otherwise, I'm going to stop sharing screen and level set on the next topic. All right, seeing none, let me switch my screen over again. I'm working with 4 screens today, so it takes me a few minutes to identify which screen I'm supposed to be looking at. All right, so board members, I want to give a big thank you. I know I went through a round of emails asking for board members to provide drugs through a drill down process of interest, drugs that the board members are interested in reviewing. A majority of the board members indicated that Entebio, Ocrevus, and Tremfya would like to be reviewed. And I guess for clarification, for public clarification, the review, the list is not the subset list. These drugs may not even show up on the subset list. The intention was for board members to submit to staff ideas or drugs that they wanted or to consider for review based off of the initial drill down process. So these are the ones that were provided through from different board members. The ones with the asterisk are the Chair Bailey, before I go, I want to acknowledge your hand.
Thank you.
Yeah.
Sorry, I was just trying to pull up something, but I mean, I think the lens that we were discussing, kind of doing some of that preliminary feedback on was, I'm trying to find my email right now, but it was can you just for the record share what was the lens that the board members looked? We had kind of a couple ways that we were looking at it, and I just thought it would be prudent to share that.
Let me draw that out here. So
we'll see who finds it faster, right?
So the drill down criteria, I'll blow this up a little. Okay. So board primarily focused on brand name drugs. Discussion was to remove antivirals, toxoid, and vaccines, and additionally remove therapeutic equivalents and biosimilars. Remove drugs that were previously determined by the board as the impact, which was, Cosentyx, Trulicity, Vraylar, and then for the insulin drill down would have been the Solostar, Lantus-Solostar. And then board was to provide options between the drill down of the one filter based off of the highest to lowest net spending, and then the other one was the highest to lowest spending per enrollee.
Thank you. That was the piece I wanted to make sure to share.
Yeah, so due to majority of the board members just kind of submitted everything in general, it just became a lot easier for me just to put everything into one collection concept versus trying to go back and say, can you please split it out? Can you please split it out? Like, what is your
No, I just wanted to share those two lenses that we were
Yeah.
looking at: total annual net of rebate spending, as well as total annual net of rebate spending per enrollee.
Yeah, so those were the drill down concepts. So together from those two, this is the list that was submitted. I was going to indicate that the asterisks show drugs that have an orphan condition. So these are drugs that treat orphan conditions, and I will speak in just a moment about the concept of the orphan tiering. But I wanted to level set with the board members, since this was a project that you provided staff to kind of level set initially that these are the drugs. And then I will show you the insulin products. Maybe. Okay. So insulin products, we had a handful for the Humulin RU500, and then there's also the Humulin RU500, the Quick Pen, Limjib, and the PS Flex Touch were also considered, but with the current or the updated statute language that's going to be approved by the time the board has to determine an insulin product, you can select all four of these or the one primarily one. So again, the list is not the subset list of selection. These are just the concepts that each board member had an opportunity to provide so that we can facilitate a meaningful discussion today. So before moving on, I just wanted to provide board members any opportunity to ask questions regarding the submission of the high-level stuff. I'll come back to this as the conversation continues to be facilitated, but I just wanted to put this out there ahead of time, since it wasn't the numbers were not in the material packet, but the drugs were. Alrighty. So again, I apologize for the stopping and sharing of my device, but if I don't stop, then my one screen is not happy with me. All right, so moving on. It is time to talk about the preliminary lists. So sharing the screen. All right. From last, oh, sorry, Dan, I see your hand up now.
So I'm sorry to interrupt, but I was just wondering, Chair Bailey, if I was just looking ahead at the agenda and I see there's not too much after this discussion and this. Do we want to take a short break now?
I think your recommendation related to timing, so that we don't kind of put ourselves in a position where we have great discussion and then we have to pause. So if you're suggesting a break, 5-minute break right now, that's something that's agreeable to me.
Spend 2 hours. I think it's reasonable.
Yep.
All
All right. Well, for the record, we'll take a break now at approximately 10:01 a.m. Pacific, and we'll return at 10:06 a.m. Pacific. All right. Well, welcome back, everyone. Melissa, if you don't mind calling a quick roll just to make sure we have quorum to proceed.
Okay. Chair Shelley Bailey.
Present.
Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Shel Coder. Chris Lehman.
Present.
John Murray.
Present.
Thank you,
We have a
Melissa.
quorum.
So it appears we have quorum to proceed. Thank you. Courtney, you have the floor.
Thank you, Chair Bailey, board members. Let me go back to sharing screen. All right. again, to facilitate from last month's discussion, the board focused primarily on brand name drugs. I went through a series of removing the antivirals, toxoids, and vaccines, therapeutic equivalents and biosimilars, any drugs that were identified through the review process, and then sorted on highest net spending. Before we jump into this, I do want to just, as staff was setting information up for the drill down, there were some therapeutic equivalents that were identified through an updated documentation from our clinician. So I was able to get that posted to this morning, just to show where some of the concerns were. That should be 7. And then I try to document where those changes are taking place. So when we do the drill down on the therapeutic equivalents, there will be some that will be removed because they now show to have a therapeutic equivalent or may have a different therapeutic equivalent. Most of them, like I said, I have notes of what the change was. I do not believe it changes anything regarding the selected drugs from the board members already, but I just wanted to identify that that was an additional update as we were looking at the setup for this process. So I'm going to do the quick drill down. My computer would agree with me. Okay, starting with brand, generics. And I'm going to use the spreadsheet instead of the dashboard. I know that we have the option to use both. I think for the time being, I'm just a little more used to working from the spreadsheet. Almost done. Thank you for your patience while I get this all set up. I just wanted to make sure that it was being done in real time for the conversation. So the drugs here that I put that I sorted through the preliminary list, these are some of them do have the orphan indications into them. From last month's discussion, Dr. Hart, I'm going to give you the credit for it. You made a statement regarding, I think it was Trikafta, serving only patients with cystic fibrosis. And from there, I started looking at what other drugs on the orphan list primarily just served via the FDA label as only treating what the FDA label indicated and the orphan designation on the FDA website. So Trikafta, there's a couple others that came up, and through that developed kind of this tiering process outlined here, where tier 1 basically is the drug that treats only the orphan indication from the FDA label, and that's the only condition that the drug treats. A tier 2 is a pretty equal utilization between orphan and non-orphan indications. To note, there's no tier 2s identified or that could be identified through in the preliminary list at this time. Majority of them fell on tier 3, which was a drug that more broadly treated non-orphan indications or more non-orphan conditions, and had a higher observed utilization and spending of those non-orphan uses than of the orphan designation. So following the decision logic, where if step 1 If the drug had a broad non-orphan indication, then it would go to step 2. If that broad orphan indication was likely to drive utilization and spending, then it would stand tier 3. So I try to be as transparent regarding that process, and then just through research and utilization information determined that majority of the drugs did fall, orphan indicated drugs did fall into a tier 3. With the help of the data team, we were able to pull ICD-10 information from APAC for drugs that had that were physician administered, and was able to identify through those the ICD-10s in order to get the number of orphans versus non-orphan claims. So that's how the orphan tab was developed to determine the tiering 3 and tiering 1. And regarding tiering 1, the board cannot review those. That's very closely aligned with our statutory requirement and what the rule says. So tier 1s will not be eligible for review. Tier 3s, since they have a much broader non-orphan utilization than that of the designated orphan condition, the board can assess if that drug is worth spending time to review through their affordability review process, because the utilization outweighs the 1 or 2 handful of claims that potentially could be treating an orphan condition. And if it's a physician administered drug and we have the ICD-10, then it's we're very close to pulling out the exact number of claims. So the numbers of claims that you actually, or costs the board will be reviewing would closely align with non-orphan indications. So I know that's a lot to kind of digest from last month, as it's kind of a new process, new structure into the affordability review. But I really wanted to provide the board an opportunity to know that I know you're hearing a lot about it's against our statute. It depends on how the statute's interpreted. We've been doing this for the last close to 4 years, and we've just never had a solidified process. And now we're trying to, really solidify that process to ensure that we're looking at all drugs that are impacting the system. And that was really pointed out very strongly in the trend reporting that was submitted at the end of last year. So Lauren, I'm gonna take a pause and acknowledge your hand. And do you have a question or a comment?
No, I have a question. So when you were getting to the tier 3, you must have been looking at something that actually had ICD code number amounts, like this number of people with this diagnosis, so you could see. I mean, I'm just a little confused at how you figured out which medications were used mostly for non-orphan purposes.
Yeah, so again, we have access into APAC, which is it captures the whole system, so Medicaid, Medicare, and commercial payments. And from there, we were able to look at, pull from the FDA label, the conditions that the drug is developed to make, and then look at the ICD-10s for the conditions that are orphan-based. And so then we pulled those ICD-10s and then was able to identify the lower number of orphan conditions and that, the difference of non-orphan usage.
And again, Mr. Layham, you have the floor.
So can you address so that makes perfect sense to me, Courtney, for the things that are physician administered, like in an infusion center or a doctor's office, but for the things that are dispensed through retail pharmacies, how do you come up with those items as being tier 3 when you don't have as ready access to the ICD-10s?
Most of that information came from additional research online of what's going on nationwide. Most research that indicated a small orphan or a small treatment of those drugs. You know, so basically, however the FDA label indicated the initial drug or condition to be treated, then did a comparison of what the drug, like how often in a claim or what's the potential percentage of the orphan drug was being treated for that condition. So a majority of the research indicated that of those drugs that had, what was it, like Dupixent, you know, it's a primary pharmacy claim, but according to the research done, majority of it does treat what was it, the asthma, COPD, you know, dermatological conditions versus the treatment for bullous, can't forget, I'm probably destroying those names. I'm sorry, I'm not a physician. So, you know, it's just that comparison of what's out there nationally to kind of say, yeah, there's not going to be as many claims on this drug as there are for the non-orphan conditions. So there's a lot of time spent researching, you know, trying to crosswalk, like, you know, what's the justification? And then, you know, I wish that there was a magic ball or, you know, a way to like create the full accuracy, but I feel like the initial amount of research done helps, you know, at least create that solidification that most claims are paid on a non-orphan condition treatment. But thank you for the question. I would say that even though the research was done pulling out drugs, you know, pulling out claims for physician, primarily pharmacy-based drugs, will probably end up being a lot more challenging at this time because we're still looking at fully solidifying the methodology. But we've done the methodology a few times through the physician-administered pathway, and it's repeatable, and it's a lot easier for staff to lean into the drug like Skyrizi and Keytruda because it's, you know, primarily physician administered, being able to pull out those ICD-10s. Does that clarify?
Oh.
Yeah, I just want to make sure I answered Chris's question.
Yeah, that answers that question for me. Thank you, Court.
Okay, thanks.
Perfect.
Yeah.
Thank you. Courtney, for clarity purposes on these tabs here, is there a specific tab that identifies medical only? I know this claim we have named as orphan, but when I look forward, I see mainly physician administered on this. Are one of these tabs specifically for medical claims or? Okay.
No, that's not how this list is set up. So
Yeah, that would be part of the data. Okay, sorry about
yeah.
that. Yeah, that was an uninformed question. Sorry. Vice Chair Dr. Hartung?
To that point, though, I do think it would be informative in this and the online data thing that some sort of indicator of is it, you know, pharmacy self-administered or physician's office infusion clinic indicator would be helpful, because I think that understanding that, I think, helps inform kind of some of the other discussions around patient affordability and things like that. Just going forward, it doesn't, no response needed now, but just that's a good point that I think having some drugs have both, like Skyrizi is infusion and also self-injected, and Ocrevus infusion also now self-injection. So, but just having some sort of indicator to quickly understand that would be helpful.
Yeah, and again, it's our intention to help clarify it, but this is developed in a small amount of time, in less than 4 weeks. And so just trying to get out at the high level so that the board can drill down from the preliminary list to the subset list. And if the board chooses to look at orphan drugs, that the orphan selection is based off of the ability for staff to pull as accurately as possible information. So, but totally hear you. Yes, we agree that there needs to be some shore up on some of this information for clarity, and we'll continue to work on that. Laura, I see your hand up.
So I guess just to kind of comment on along the same lines, I appreciate that you were able to break out what was physician administered and what wasn't to some extent, because it feels to me like those are apples and oranges. There will be extra cost, I would guess, for the medical claims in the physician office. And, you know, at some point, if we're going to look at a medicine in great detail, more information on that would be important.
All right, thanks, Laurie. So kind of understanding the tiering process and the update to the Excel spreadsheet, and it does also reflect into the dashboard for those that like to have more engagement with the dashboard. Is there any other questions or anything else I can clarify before we can kind of jump over to the again, conversation to start considering a subset list? I just want to put it out there to kind of start the conversation now, because we still need to look at insulin at some points. We really want to make sure that we have both subset lists completed today in order to send in the data call. All right, hearing no questions or additional comments, I'm going to go back to the primary list. Again, with the tiering process put into the preliminary list sheet. Everything else is set up via the drill down as the board has suggested. Is the yeah, Chris, I see your hand up. I saw your hand up first, and then Shelley. Yeah.
Oh yeah, Courtney, I was just gonna say, do you want to take out the tier ones then in this filter?
Yeah, thank you.
And I only have my hand raised because I was just going to share a couple other filters just that I personally applied when I was trying to look at, how to narrow down. I don't know if, Courtney, if this is the time to share that or not.
Yeah, I think
when I was trying to think of, I mean, I know we kind of said our broad thought process, in our last meeting, so clearly followed that. But when I was also trying to further drill down, something I recall last year, I think we filtered by number of insurers of like 7 or more that were impacted. When I was trying to think of getting around, not around, but keeping in mind, trying to take into consideration what is plan design versus, something else. One of the filters I personally did apply was I was like, okay, can we go broader than 7, 7 insurers? So I started looking at like what drugs might impact 10 or more insurers. And so that was one lens I also added as a filter. Another that I personally did, just based on how our vote kind of ended for our previous affordability reviews, is I did personally take into consideration drugs that are on the MFP for 2026, 27, and 28, because even though I don't think we identified that as part of our scope last time we voted, I think naturally the vote kind of ended up removing those drugs, just the way the vote kind of ended. So those were 2 additional filters that I personally was applying when I was trying to kind of look at creating a list. Not to suggest that's the will of the board, but that was just something I was trying to view it from.
All right, thanks. And when you say the MFP list, you're saying to remove those that are already being reviewed by the.
From my perspective, I was just thinking that the although it only impacts initially Medicare, I think there is a cascading impact to the rest of the market. So personally, I was removing what's already identified on MFP. And then the 2028 MFP's actually already been announced. And then on the payer side, I was just trying to think of how can I look at what's really driving it, not just what is plan design and highly already rebated or something. And so I bumped up the number of insurers.
I guess that's we can start with discussion.
Again, it may not be everyone else's perspective. I was just sharing just to get our discussion going one way I was trying to look at it.
And it was a drill down method from last year where board members did select, I believe it was seven and more, because as Chair Bailey mentioned, that really 6 and fewer indicated like more of a plan design than an actual overall system impact.
And I don't know what is the right number. I mean, essentially it was a guesstimate on our end of what is a meaningful number that suggests plan design versus essentially pricing, unless staff had provided us with something more that got it beyond.
Yeah, the numbers are from last year, but I know it was 7 that was drill, or 7 and 6 and fewer were
Oh,
drilled
I know
out.
it was 7. I'm just saying I can't suggest that that was the right number, right? It was the number we used to help us.
I had a justification. I had to go look at my notes
Okay.
from last year. There is a mathematical justification for it. I just don't have it readily available right now.
That makes sense. So that was just one lens I was trying to look at, is what is impacting the maximum number of insurers in the state.
And just for view of that board, I will remove out 6. It really doesn't change any of the top runners. I think we're at 26 drugs as
I
it
did
is.
10 I did 10 or more, just trying to.
I don't know if any other board member has feedback or has an interest in drilling out, number of insurers that report the drug as having an impact to them on either the greatest increase, most costly, or most prescribed. If there's a preference in drilling out more or removing more insurers that reported. And if hearing none, then you can just put it back to the number. Yeah, Michelle, I see your hand up.
Sorry, I do support that approach. I think we want to maximize the benefits of the work that we do to the population. When you do 7 or more, you're getting to over 50% of the carriers. And I think, we can further drill that down to 75% if we think that's appropriate, but I do think it's an important consideration.
Understood. Any other feedback or suggestions from board members? So I hear to be a little more, does the board want to review 8 insurers, or do you want to stick with 9, 10, 11? I have 8, 9, and 10 here. Yes, Dr. Hartung, I see your hand up.
All right, how many carriers what are the total number of carriers?
11.
Okay.
So just falling back into what we did last month or last time, 6 and fewer were removed. If board would like more, please let us know. We can drill out more. Have a conversation on it. All right. Is there anything else that the board would like to look at? Again, right now, this is, it's drilled out on the total net of rebate spending. We can also do the spending per enrollee. If there's anything kind of through this option that the board's interested in reviewing.
I mean, from my perspective, while I appreciate total annual net of rebate spending per enrollee, I think it's not fully capturing the net because of manufacturer assistance. So I was more focused personally on the total annual net of rebate.
Yeah, I understand that.
And then the WAC changes and I mean other things too, but I don't want to take the entire floor.
Well, I guess since we have a handful of top spending based around orphan drugs, um, I think for the realization of the work to parse out claims for orphan and non-orphan conditions, it would be I think a little more within a little more accurate to only have like two, no more than three orphan drugs to review. So would the board like to start with picking only, a couple of orphans and then look at the other drugs? So then I can just drill out the orphan considerations in this and kind of shore up the list some more.
I mean, from my perspective, Mr. Murray, your hand is raised, so you have the floor.
Oh, you're on mute.
I was going to continue on with Courtney's thought there of selecting 3 of the top annual net of rebate spending orphan drugs in tier 3. If we just kept those and set aside and remove all the other orphan drugs, what would happen to the list? If we're challenged on ability to evaluate orphan drugs at all, then, and we have 7 orphan drugs on our final list, I think we would find ourselves short on.
I mean, I think to lean into your comment, Mr. Murray, it seems to me that also focusing on the lower number of orphan designations would probably be appropriate related to what the data lift would be. But Vice Chair Dr. Hartsong, your hand is raised. You have the floor.
Yeah, so I definitely think we need to consider the number of orphan drugs we want to put into the docket. I do think that there are some qualitative differences in just the number of orphan indications and the just in my view of the work required to split out the orphan from the non. So I don't think like just because Keytruda, for example, has a lot of orphan indications and they're all, they're somewhat related to some of the non-orphan indications or specific subtypes of cancer. And so I could see that getting really messy. Although it's also a huge expense cost center too. So I hate to like not review that just because of the complexity there. So, but some of these are, I feel like would be fairly straightforward. Like Entyvio, or it's got one orphan indication, pouchitis, but also indicated for ulcerative colitis and Crohn's. So, I feel like, it'd be pretty straightforward to kind of pull out the non-orphan use. So I think it should consider both the number of orphan indications, the kind of the ratio of the number of orphan indications to non-orphan indications, if that makes sense.
And just to kind of clarify this, which I think is important. So because Keytruda is primarily a physician administered drug, we have the ICD-10s for the orphan and non-orphan indications. So we've already parsed out, because this was one of our test drugs. So we've already parsed out what those what the claim removal would be between the orphan and non-orphan conditions. So Keytruda could still be a selected drug because it's physician administered until we have the ICD-10s. A challenging drug would probably be the Dupixent, which again, this is based off of, primarily pharmacy-based claims. And we really have to do a lot more finessing and creating some sort of more accurate claim pool for those ones. So going back to kind of the drill down, I highlighted in, this lighter pink, both for the top spend of for rebate and Renroli. And these are the 3 that came across, like, they just are different order. And I think Entyvio is also, so Entyvio is orphan and non-orphan, so we can pull the ICD-10s off of the ICD, we can pull the ICD-10s from the PA or the physician from the medical side and then cross it over to the pharmacy side. So those 3 drugs that are, you know,
Can we go back to that previous?
the orphan?
Yeah, so like on the Intivo example, does that, and this is more a question for the clinicians here, does that mean that 100% of the time, someone that's on Intivo always has an additional dosing that's an IV? So like it would always be medical first? Is that essentially what you were alluding to, Courtney?
That's my understanding.
Okay.
Again, I'm not a clinician, but from all the claim and research done, the initial is usually an IV, and then it falls over to the personal infusion or the injection. I see, Sarah.
Yeah.
Just one point on APAC data that one of the limitations we need to keep in mind is that we have the data for a year. So if somebody started therapy the year before, we wouldn't necessarily have the claims for the initiation of their therapy. We might only have the claims during the calendar year we're looking at for the continuation of their therapy. As we're continuing to build out our analytics skill with the APAC data, looking at multi-year analysis is something that we could work toward in the future. We're not there yet, frankly, as far as analytic skills. So the patient had a physician-administered initiation. That initiation may or may not fall in the year that we're looking at.
Thank you for that clarity. But back to Courtney's kind of comment about even though there's 10 indications like on Keytruda, it seems as though like in the Keytruda example, it's 100% physician administered. So in the data call, we would have the ICD-10s for all the claims. I mean, is that an accurate assessment?
Yeah, we've been able to pull the ICD-10s for that one.
Mr. Murray?
Yeah, dependability of the data is important to me. That's a subtle point that Sarah brought up, but one that could skew the data or add ambiguity to it. So anything of the 2 or 3 orphan drugs that I would be interested in, I'd like to have complete confidence in the ICD-10 codes and the separation of orphan versus non-orphan designation, if possible.
And go ahead, Dan, if I make comment.
So I guess thinking about the pharmacy dispensed drugs, do we have the ability to link pharmacy claims, patient identifiers to the medical claims through patient identifiers to just screen for orphan conditions? Because that would be the way to do it.
I would need to lean into Pei and Heather to come on camera to describe that. That's kind of one of the thoughts that I was thinking, but it hasn't been tested, so I would have to ask my data team. Pei or Heather, if you can come off.
I can speak to part of that while Heather's getting her system working. And yes, we can identify individual patients in the data file, and we can relate if a person had both medical claims and pharmacy claims. We can look at how those relate to each other. Again, just like the point I made for the earlier question, we are limited to 1 year of data. So that's a limitation if the patient's treatment started prior to the year that we're analyzing. Also, we only have medical claims that included drug codes, NDCs. So if a person had medical claims in the APAC system that resulted in various treatments and diagnoses, but did not result in a drug being recorded on that claim. We don't have that claim in our current analysis. Anything to add to that, Heather?
I would just say that both to kind of elaborate on what both you and Courtney said, it's untested. We haven't tried it. Can we crosswalk, to answer Dan's question, by a unique individual? Yes, but we haven't done it. And the limitations that Sarah is stating are consistent throughout that.
Well, that's a big limitation in terms of not having full capture of potential diagnoses. That being said, it's also important, I think, important to recognize that orphan indications are orphan because they're for conditions that affect fewer than 200,000 people in America. And so just by designation, they're very rare. So I'll just leave that there.
So I guess going into even, Dr. Hartung, your comment, and John, what you were saying, we're still working on the data, right? We can only work with what we have and the concepts that are available to us. If the board believes that it's not vetted enough and not at its full capacity, because this is a newer concept for this review cycle, the board does not have to select orphan considerations at this time, and staff can continue to work on a methodology that is a little more structured to see through the testing and stuff like that. Again, that's why, the recommendation is, only a couple drugs, orphan drugs, to parse out or test the review process with. But since it seems to be some concerns with the limitations of what APAC and POL provide, I think it's part of the conversation if the board does want to continue looking at orphan drugs for this review cycle or not. So Lori, I'm going to acknowledge you, and then Chair Bailey.
I guess I was wondering if you use the filter of eliminating the orphan drugs that are given, treatment is done two different ways. So some of the claims would be medical and some would be pharmacy. If we could just simplify and eliminate that, that might help us drill down on the orphan drug choices. Because that's going to, even though it's convenient to have the codes, it's also going to be complicating because every patient has their own treatment plan.
Ms. Coder?
I agree, but I also think there are some drugs like Stelara where we have age data whereby we could easily exclude that orphan indication.
And to lean into Ms. Coder's comment, I was going to say the same thing. I like the lens that Ms. Hoagland shared, but I was also going to reference Skyrizi because that, similar to the Stelara discussion, that's an age-related orphan that I think our team could easily handle. So I wouldn't want to exclude those two, at least ones that have the age-related, because I think that piece we can find confidence in the data.
I'm looking through, I think those are the two primary ones. Oh, here we have Spravato, but it's not as towards the lower end. This one has pediatric, but multiple other indications, and it's a.
But I think on the pricing piece of it, at least, that comes up so low that it's less relevant.
Apologies, I just lost my headset. Are you able to hear me?
Not as well, but we can hear you. Sorry.
Yeah, all right. Give me just a second. Let me switch over to another set.
So while Courtney's switching over, it looks like this screen does not reflect what some of those filters that we were applying. Because I think this is the same screen that we were looking at before we were applying some of those filters.
Yeah, this is the preliminary list. So
This is
again,
much better. Thank you, Courtney, for your audio correction.
yeah. Sorry, it only lasts as long as I could get them charged. So again, Skyrizi orphan consideration is just based around pediatrics. Keytruda is primary physician administered, and Entero is one orphan indication, which we could probably grab the ICD-10. It may be a little bit, again, have more challenging methodologies. But if the board is looking at two, then we can confidently do Skyrizi and Keytruda. So I see a lot of head shaking, but I want to make sure before I make any assumptions that board members provide staff with direction. Dr. Hartung, I see your hand up. Oh, you're on mute still.
Never mind.
Okay. So again, not making an assumption, but I saw a handful of heads shake. So is the board interested in moving Skyrizi and Keytruda to the list, the subset list for review? Dan, I see your hand up again.
Sorry. So, I guess I was wondering, kind of with the thought of like next year or next cycle, is it possible to include one of these more complicated, like Dupixent, potentially complex ones where we could have the data team explore this linkage, even though we know that it's likely to be incomplete, just so we have some sort of template for maybe the next cycle.
Yeah, we're always working on data projects, and I'm sure we can work to solidify that process, that methodology up to more accurately capture those pharmacy provided drugs. Yes, Mr. Kennedy, I see your hand.
Yes, I just wanted to state that I am comfortable moving forward with Skyrizi and Keytruda as the two choices.
Okay.
To go with the head nod, yeah.
The multiple head nods. Perfect. Thank you. I'm just going to highlight those green for now. Any other comments from board members? I appreciate, Dan, the complete solid yes.
Yeah, I would support that too. This is John.
All righty. Got two board members. I feel a lot more comfortable if I got a couple more yeses.
I feel comfortable with proceeding as well.
Okay. All right. Well, we will dive into those two orphan drugs through the process. Thank you. I think that being able to remove the orphans out of the list and focus on the other drugs will help get us down to how many drugs that the board would like to review. Is the board interested, I guess, maybe setting a number of drugs to select at this point, knowing that you've identified two? Your statutory requirement is 9.
9, yeah.
Up to 9, yeah. So
yeah,
probably want to select a, probably 10 or 11. Safe zone would be 12. To go through the data call, and then if any of those drugs come back through the data call, showing additional information to be dropped off, there's always that option or possibility too. So, and we have 18 drugs counted based off of the drill down and removal of the orphan drugs. As Chair Bailey, oh, go ahead, Chair Bailey.
Right, if you remove orphan, because like obviously we've discussed that. I mean, I would like, I guess I would welcome, the board's thoughts on, oh, go ahead, Sarah, you have the floor.
Oh, didn't want to interrupt you, Shelley.
Oh.
I was just going to suggest to Courtney that it might be helpful to just review the filters that you currently have applied to this view of the list to make sure everyone is following where we are.
Yeah, so again, looking only at brand drugs, we had antivirals, toxoids, and vaccines have been removed. Any drugs that have a therapeutic equivalent or a biosimilar has been removed. Cosentyx, Trulicity, and Vraylar have been removed because those are already identified by the board, and it's currently filtered from highest to lowest on net spending. We also removed carriers that reported the drug of 6 and fewer, So that is where we are in the drill down. And removed all the orphan from the current list because we selected 2.
So a couple filters we might want to consider, or at least discuss considering, would be whether or not we want drugs that have previously been on a subset list, as well as how does the board feel about evaluating drugs that have an associated, MFP, even though not for the 2024 timeframe. That's just 2 kind of filters I thought maybe is worth discussing. Vice Chair
Yes,
Dr.
Dr.
Hartman?
Yeah, I think that we should continue to review drugs, even though if they have been on our prior year subset list, just because the dynamicism of the market, and it's good to keep an eye on things. I don't think we should do any filtering based on the Medicare drug price negotiations. I think we can consider that in the affordability review itself, but I would be hesitant just to exclude them just because Medicare has done this, is starting to proceed down that path. To the point of it was brought up in public comment today that Virginia's new PDAB is one of their priorities is basically just implementing Medicare's work and implementing their MFP in the commercial side. And so I think we can learn a lot from just understanding their deliberations.
Thank you. So I think with that feedback, Courtney, you said that gets us back to our preliminary list. Did you say there was 18 that met that criteria? Ms. Hoagland, your hand is raised. Do you have the floor?
I guess another one that we may want to consider eliminating is the Perchetta, which is usually given in combination with other medications with cancer. And, so it's really, you're not really looking at the impact to the patient with just the one medicine. It's a more complicated view.
I think it already fell off due to the drill down as it is. I'm not seeing it.
And while you're looking for that, Ms. Coder, your hand is raised, so you have the floor.
Thank you. I just wanted to voice support for Vice Chair Hartung's comments, not removing MFP drugs or drugs previously removed. I do have a question for the board. I was present for 2 of the meetings where affordability reviews occurred, and do we want to have a conversation on what the board feels is a reasonable number of drugs to review each meeting? Because I felt like we spent a lot of time looking at data when we had 4 or 5 or 6 drugs to review, and there wasn't a lot of time for discussion or deliberation.
Well, and I think that question directly aligns with the question Courtney asked of us, which is what is our TAM for the subset or for the preliminary, subset list. So I think Courtney, reminded us that our new statute is up to 9 drugs. So, as a board, are we back to your question, Ms. Coder, about how many per meeting, and I think Sarah referenced we might begin these in, was it July? Getting the data based on the information we get back in the data call. You know, is it the will of the board that we look at 10 drugs? Is it the will of the board that we look at 6 drugs? I mean, what would board members like to do related to that?
Well, I think due to the language of the statute, it's safe not to go below 9.
Below,
So,
okay.
yeah.
Yeah,
so
and I wasn't suggesting that. I was just saying since it was up to, I didn't know if we had the flexibility to look at 1, if that was our intention, not to suggest that it is our intention. But Ms. Hoagland, you have the floor.
The other thing I was thinking, number of enrollees. I think 100 was our kind of
Minimum. Yeah, that's a good point to call out.
we
I think
maybe
that
want to call out, here's one that's 117. That's, call out a couple. That seems like that might be a way of decreasing our numbers.
Vice Chair Dr. Hartung, while Courtney's applying those filters of approximately 100, you have the floor.
Yeah, I mean, I agree with the sentiment of about the number of enrollees. My concern is that because this is compiled from these lists from the carriers, it's somewhat an incomplete reflection of the entire commercial population in Oregon. So on the margins, like around 100, I feel like if you had the full APAC picture, there might be more, maybe significantly more, because we're only seeing, what carriers are, maybe a select number of carriers are reporting. And so I guess I would be a little bit more hesitant to apply a strict criteria around the number. I mean, if it says 1 or 2 enrollees, I guess that's maybe something to exclude, but yeah, that's kind of how I fall on there. I mean, that's generally how I fall on just applying criteria after criteria, is because like this is a kind of incomplete, because we're again, it's like these drugs are sporadically reported by carriers, and then we're compiling them into this big data set, and so it's somewhat of an incomplete picture.
I wanted to ask the board, last review, there were a handful of drugs that ended up coming across in the same therapeutic class, and it was indicated that that was kind of helpful. So I wasn't sure if that was another option for board to consider, since there's a handful of anti-diabetics, and kind of focusing in, since that's kind of a hot discussion these days around anti-diabetics. If there's kind of looking at migraine medicines, the same ones from last time though. Dr. Hartung, I see your hand up again.
Yeah, well, I think I'll own that comment because I think I made it. I guess I've kind of reconsidered that, given what the reports look like, and that I think there was a lot of effort to bring in the therapeutic alternatives in these reports. So it's not as clear to me if that's should be an important driver, like kind of having clusters of drugs, because the reports themselves will reflect the therapeutic alternatives regardless of whether they're on the subset list or not.
And the dashboard helps with that greatly, at least from my perspective. When I'm looking at it and I'm looking at the dashboard, that definitely helps guide during the review process.
Any other
So, I mean, thinking just strategically of back to Michelle's question about starting in July, wanting to have a report, by the end of the year. I mean, I would say that from my perspective, we would not want to go beyond 12 drugs and maybe consider like 3 drugs per meeting. I would say that should be our max from my perspective. But that's just one way to look at it. Mr. Lyman?
Yeah, Chair Bailey, I mean, for me, I would be fine with 9. If it's up to 9, that's our requirement. sorting this in a way and then choosing the top 9 that we see, or 7 if we're going to include those other 2 orphan drugs, and to make a total of 9. I mean, that seems very reasonable to me, and it should allow us to have more thorough discussion about each of the reviews.
I'm not against that. Again, keeping in mind, the role of our board is advisory in nature to the legislature. The more time that we have to work on things, the more, fruitful discussion and information that we're able to provide in an advisory capacity. Do any other board members have feelings related to the number of drugs that we review? Mr. Murray?
Yeah, I would go with 9 as well, please.
Mr. Kennedy?
I'm also good with 9, but am open to an extra in case of unforeseen circumstances. So 9 to 10.
Makes sense, Mr. Lehman?
So Courtney, if we sort based on column K, total annual net of rebate spending, from highest to lowest, and you remove that filter that you had for the orphans, how many orphans would be in that 9, the top 9?
Okay, hold on, please. Three, 4, 5.
Okay.
And
I just wanted to see, I'm reticent about pulling it out because it's hard, but I get it if it's more than half of them. I mean, I was in my head thinking maybe it would be 3 and we'd only have to add 1 more.
Well, and I think back to Mr. Lemon, I'm glad that you suggested looking at the filter that way. I think based on our discussion a little bit earlier, I think 2 was going to be our max.
No, I get it. I was just
Yeah,
trying
you were
to
just double checking. Yeah.
Is there any other? So I think we're at 18.
Michelle, your hand was raised, or I think your hand was raised first.
Thank you. Do we, question for the board staff, do we know approximately how many lives are covered by the APAC data?
In total, or as far as for 2024? And
Just in general, I'm going back to, I think I want to challenge the filter by enrollees, because I think the APAC data includes the prominent carriers in the state.
So to clarify, these enrollee counts are not from APAC. These enrollee counts are from the DPT data call, which are not the DPT data call. I should use my terms correctly. The DPT annual report by the insurance carriers, which is limited to the commercial carriers with fully insured programs, fully insured plans. The DPT data report includes approximately 25% of Oregonians when we look at the numbers of people in that fully insured regulated group. The APAC data, APAC is missing some of the ERISA regulated insured people, but has pretty much everybody else. So some of the analysis that OHA has done is between 60 and 80% of Oregonians have information reflected in APAC. So that's kind of the difference in where we see the population covered between the DPT reported data and the APAC data. Does that answer your question, Michelle?
Yeah, that's important clarification. Thank you.
Yes, multiple data sources gets complicated.
Michelle or Ms. Hoagland, your hand is raised. You have the floor.
So if we need to get from 18 down without extensive discussion, I wonder if we went back to Shelley's comment about number of insurers and maybe put that list at 9 or 10 to see how many automatically drill down.
8. So for carriers 11, 10, 9, we have 8. If we removed 9 and just focus on 10 and 11, we'd have 7.
Or even maybe going to 8. I mean, the other part I want to not lose sight of is maybe also WAC increases. You know, I think that's something that, you know, in the past we've definitely tried to keep mindful of. Clearly, there's also shifting market dynamics that some drugs have WAC decreases, but that was another lens when I was doing internal filtering that I was looking at.
Well, with the drill down of only focusing on 9, 10, and 11, you have a count of 8.
I think
but-
that's too narrow in my opinion, but
and then the 2 insulin or the 2 orphan. So it's 10 altogether.
Yeah.
Good point. Vice Chair Dr. Hartung?
Is the number of insurers, is that reporting across all 3 lists that they submit, or is that
Yeah.
any list?
So you can see here that the carriers reported on greatest increase, most costly, and most prescribed. So 100%.
Okay, so those, whatever we have to set it, they have to have the drug reported in all 3 of those lists?
They do not have to be reported in all 3 of them,
Or
but in
any
some
of those lists?
capacity.
So they had to be in one or more of those lists for each carrier to show up. This doesn't show. So all of the carriers had Ozempic on one or more of the 3 lists. This isn't telling us that all of the carriers necessarily had Ozempic on all 3 of the lists. If that distinction is clear.
Yeah.
But some carrier, at least one carrier had Ozempic on each of the lists when we aggregated the data together.
Courtney, something I also see when we look at it this way, again, when I was doing it, I had some different filters, so my list looked different. I do want to mention, it doesn't mean we shouldn't review it, but Farxiga, for example, now has a generic on the market. Again, I know we try to keep our lens to the year in which we're reviewing, but I thought I would call that out.
Okay. So again, you said it's going to have a therapeutic equivalent to it?
It has a full generic.
Okay.
I mean, it's on the market now. I mean,
okay, so I did have it originally as 1. Clinician review showed that it actually does not have 1. So
Mr. Murray or yeah, Michelle, you have the floor. You're a pharmacist. You can answer that.
Farxiga has an authorized generic, which is manufactured by the manufacturer of the brand. A full generic is anticipated to be released this spring.
okay.
Yes, absolutely.
So there's no market competition currently, nor was it in 2024.
Correct.
No.
Xarelto also has generic.
Yeah, I think that was original results of research show 2, however, clinician results in 0. So based off clinician review, it was dropped to 0. So Xarelto, when did it come on within the last couple of years?
As a single source generic, right? I mean, I just want to mention that, obviously even single source generics still, have a decrease on, payer.
Yeah, they do.
So how would the board like to handle these two drugs that have originally indicated some sort of generic, but clinician reviewed showed 0 to change to 0? So do we want to go back and look at a higher number of carriers or remove these two?
I mean,
And
Vice Chair Dr. Hartson has his hand raised.
yeah,
Yeah, I mean, I think that we should, I guess I'm hesitant to keep applying filters because I think we can kind of set a base number of filters, and I think doing something, we maybe need to loosen up the number of carriers a little bit, and then just we have it sorted on spending and kind of we have our collective knowledge about what drugs, have either a current generic on the market or something that's going to be imminent release this year, that we can just make a mental note and say, okay, that one's we're excluded because there's a generic available, as opposed to getting caught up in these details about how these flags are populated and things like that. So I guess that would be my preference for a way forward. And if we're only going to go to 9, those might fall further down the line anyways.
Mr. Lyman?
Yeah, I mean, I agree with Dr. Hartung completely. I mean, and for me, it's the top 7 with this sort because we have the 2 orphans that aren't on there. And using that, the system that we've already talked about, and I think everybody's in agreement to this point of how we filtered things, and then just picking the top 7 on this list and adding the 2 orphans that we talked about. I don't know how you feel, Dan, but
Yeah, no, I feel like that makes sense. And I'm still a little bit foggy on the number of insurers and the list number. Just need to think about it and look at it a little more deeply. But,
But
in
this keeps
general,
it the same as we did last year. You know what I mean? So like
yeah,
we haven't, it's kind of a standard way that we're developing and how we're gonna sort this. And instead of it having this kind of subjective discussion about filters, we're moving toward having a standard process every year that this is how we're gonna sort the list.
I agree. And I also, just to add that, we can consider all these things that we've discussed about during the affordability review. So this is just to get to this subset list, and then we can have they're very meaningful conversations, but just during the affordability review about WAC increases
Yeah.
and
And I
MFP, stuff like that. So
And I don't disagree at all, Vice Chair Dr. Hartman, with what you referenced. I do want to make a comment that I think one thing we want to keep in mind as a board is that we may not want to have a standard filter list each year because we do have the flexibility to completely look at things from one lens in one year and a different lens in another year. One and I'm mindful, obviously, of the time left in the meeting. One thing I kind of was seeing originally looking at it this way is that, I mean, a lot of the drugs have been on previous subset lists. Again, doesn't mean they're not important, but I just want to tell the board that we do have the flexibility to completely look at things one way one year and one way another year, so that we can make our kind of advisory reports as meaningful and dynamic as possible. Mr. Kennedy?
Yes, I would just like to echo what Chair Bailey said, with the statement that we may actually learn things from year to year too. So we may filter differently based on what we learned the year before. So yes, good recommendation, Shelley.
So as the conversation has been going on, I kind of highlighted the top 10, the net rebate spending and then the net rebate spending per enrollee. So you can kind of see where the crossover between the drugs are. So these are the top 10 here, these drugs, if the board wanted to select any, or 1, 2, 3, 4, 5, 6, 7. There's 7 drugs that fall in both of the both columns. So, you know, kind of taking those 7 and then adding the 2 orphans, I know it kind of really provides a very, very narrow, and that will pretty much be your list of subset to review. In the sense where you really probably don't want to go below 9. I know that the statutory language says up to 9. But I really want to make sure that you're at least at the cap of what that language would be. So yes, you have the ability to review 5 or 6, but I think for the initial subset selection, ensuring that there's 9 on that list, if the board determines that some need to fall off, they're still within that guidance from what the statute is indicating.
And Courtney, just looking at this as you filtered it, does this show that 6 of those 9 have been on our previous subset list? I've been trying to count as.
What?
Yeah, I don't want to mess up your filter.
4. Yeah. So 6 have already been previously reviewed by the board. So
I'll go with the will of the board, but I think if 2/3 have been on a previous subset list, that might not be the approach we want to take, but.
yeah, because the staff already tracks trending, so have a trending report at the end of the year that's still going to kind of show the trends from one review to the next. However, reviewing the drug, I don't know the steps that would be any different from material packet information, short of just equated differences from one year to the next, and they could be marginal because they're already showing to be consistently high year over year from the DPT data that's been going on for a few years now. So again, kind of the will of the board, if you're interested in reviewing again drugs on the subset list, just know you're going to be reviewing 6 that have already been developed. Staff would be able to basically do price trending comparison. We still pull the same data, but then you'd be able to see comparatively between the 2 years. And just to be mindful of time, we still have to discuss the insulin. I know that there's not as much of a press for insulin products, but I do want to allot time so that we are collecting both drug and insulin products to send in the data call. Is there any preference if the board is going to lean into list as shown, which includes drugs already reviewed on the subset list from last year, or I can drill out subset lists and we can look at the top 10 between the 2 columns. Yeah, Dr. Hartung.
I guess I think it's probably okay to review these drugs again. I think that, even, we're still in the process of evolving and refining the affordability reviews themselves. And so I think that there might be some new insights that are gleaned during the next cycle, especially if we have multiple years of APAC that inform it. So I don't know. I'm less troubled by that, but that's where I'm kind of landing.
Any other comments from board members?
I mean, while I support whatever it's the will of the board, from my perspective, I guess that's kind of why I leaned into trying to figure out what drugs impacted the maximum number of insurers, trying to also be mindful of not, we already discussed that we would have 2 orphan drugs and not adding to it. But I was just trying to look at it from the lens of trying to eliminate some of the barriers that plan design might influence some of this. So that was just one lens. I mean, I certainly want to, be involved in work that provides, the maximum kind of information for the legislature that's meaningful. And so that was just why I evaluated it from that perspective. Mr. Kennedy?
Yes, I want to say that I'm comfortable going with drugs that have been on the subset previously. I think it's unavoidable, basically, that we're going to find repeat medications on different lists year to year. So I'm okay moving forward with drugs that have been on the subset.
And Shelley, just for clarification of your comment, I just looked up the statute language, and it does say that part of the responsibility is to determine the impact of patient access on drugs considering standard prescription drug benefit design. So even if the board looks at, the insurance numbers, and then we're kind of identifying the plan design, it's still within scope of.
Oh, yeah. And I mean, for the record, I want to be clear. I expected that we would definitely have drugs from previous subset lists on our list. I was just kind of making us aware, do we want 2/3 of our new preliminary list to be drugs that we looked at last year? So, but I fully expected drugs that were on our previous subset list to clearly come up again.
I'm kind of filtering out here. So these are the 7 drugs here that are on both lists. Is this the list here? Ozempic, Ocrevus, Trampa, Verzenio, Zolar, Emberovi, and Nordic ODT, and then the 2 orphan drugs, Skyrizi and Keytruda. Chris, I see your hand up.
Not to put you on the spot, Dan, but could you talk again about the concerns you had about column N? I wasn't quite sure. You said maybe it doesn't accurately reflect the actual out of pocket costs for patients. I'm not sure I followed that comment that you made earlier about column N.
In this one?
Yeah, N, like
Okay.
Nancy. I think you were raising some concerns about that column, right, Dan?
Yeah, so I mean, when I was thinking about this, I think that column K reflects kind of just impact on the system, probably as well as out of, patient burden in terms of how much their patients are spending out of pocket costs. But the annual spend per enrollee seems to me to be tied closer to what a potential patient might, so very expensive drugs for the individual patient might have a higher out-of-pocket cost if their insurance design is tied to the cost of the drug. I mean, it's kind of a couple steps in logic. But so that's kind of in terms of looking at the lens of drugs that may have a outsized impact on out-of-pocket cost for patients. That seemed to be, to me, something that would be unique and distinct from just total cost to the system. If you filter by that or sort by that, you get these you get a lot of the orphan drugs or cancer drugs kind of front loaded that I think are maybe a little out of scope and or we're restricted from reviewing. So that was my kind of the comment there.
And Dr. Hartung, you're correct that the spending per enrollee is based off of what the payers pay for that enrollee, right? Versus we don't have yet, because this is the carrier cost. We don't have that patient out of pocket cost. We have to send it back to the carriers through the data call, and that's how we get the patient out-of-pocket cost amount, because that's where we figure out that difference. So you're right, those two columns are primarily aligned with system because we do not have access coming in or data coming in for patient out-of-pocket costs at the net level until it goes through the data call.
Well, yeah, we could also, if we wanted to, we have APAC data has out-of-pocket costs in it too. So,
yeah, I mean, we're going to pull that as well. Again, this is just that, the identification of what drugs the board wants to look at. We'll pull APAC data for all these drugs. We'll do the gross and then send it through to the carriers, get the net, and then that's how the packets are developed.
right.
Well, and Courtney, I did want to go back to kind of just the number of drugs in consideration. I know with our revised statute, right, it's up to 9 drugs, right? So, I mean, I know we don't want our subset list to be too narrow, but again, it's up to 9 drugs. So, that
and how it is, it meets that.
Pardon me?
And how it is with the 7 plus the 2 orphan considerations, it meets that 9.
Mm-hmm. And Ms. Hoagland, and that's without an insulin product, right? But Ms. Hoagland?
Yeah.
So I guess I'm kind of leaning a little bit in your direction, Shelley, with wondering, since we're not applying patient impact with the out-of-pocket yet, when we apply that later, if the drill down may really eliminate quite a few medicines, and we might do better to have a few more now and the staff work will be a little bit less, I would guess, because they worked with some of these medicines in the past, but maybe I shouldn't guess that.
We've worked with the same medicines that the board has as far as setting up the material packet. So that's, where we're at with that. But I mean, again, it's at the board's discretion. I do want to be mindful of time to have a conversation around the insulin or have concern that the meeting will run over to get the last. So does the board want to look at one of these columns a little bit more closely? I know I separated this out.
Where did Xeljanz go? Did that get cut out somewhere? That was on a. I'm just looking at this kind of summary document, and like 3 board members selected it, and so I'm just curious where it fell off.
Probably probably through one of the drill downs.
If we're trying to like diversify into to drugs we haven't looked at before.
Yeah, and just as a reminder, sorry, I have to run it through screen. So this is the drugs that the board is looking at or submitted, and 3 looked at or considered Xeljanz. But I think it fell off in one of the, I'm trying to find it. Trying to decide how far back I have to go on the review, maybe in here.
Brittany, if I may, I believe it fell off in the number of carriers potentially.
Yeah, that's what I'm
I'm
pulling.
not positive. It had 6. Potentially not, though.
Yeah, right there. All right, so I'm just gonna pull it up independently. So it had 6 carriers associated with it, but everything else went. So just some. I'm sorry, no, that's kind of small.
So it was excluded because of the carrier thing.
Yeah, because when we drilled out this 6 and fewer, right here for number of insurers. That's what created it to fall off. Yeah, and I know that we've been going through the list. We also have 1, 2, 3, 4, 5. There's at least 5 drugs here on this list that multiple board members are interested in. And I apologize for having to throw the sheets back and forth. Okay. So Ozempic is coming up as a top paid, okay, but again, board members reported not having too much interest in, because Ozempic was on a subset list last year.
Well, and I think that's a little bit of what's problematic for us to look at this and the other is because we've kind of applied some filters together as a board that probably change, what different board members would have voted for. Same, I mean, certainly the original list I provided is modified based on, the new filters we've applied.
Yeah, but even if we look at the top, Jetta, even though Laura, you made a comment about project, and this is based off of the filters of 6. I didn't go back to doing 7, so. Oh. Jaro is not on there. So these are still within your top. So if the board wanted to look at, again, these top interests, right? You have 5 here. You can add in Xelgens, and then either one of these anti-diabetic ones or all, because they're all probably going to be each other's therapeutic equivalents. Oh yeah, Chris, I wanted to acknowledge you.
Yeah, I think you can highlight the 2 orphans that we talked about, right? Keytruda and Skyrizi that are on this list that we said we were gonna include, right?
Yeah. So 1, 2, 3, 4, 5, 6, 7. So right there's 10 based off of both what is selected on the drill down method and what board members have selected. The yellow highlights are equate to 10. Yeah, Chris, I see your hand up.
Yeah, and I mean, to me, that really only filters out the orphan drugs that we had a long discussion about wanting to filter out anyway. I mean, the Eliquis is on that list, but I mean, that seems like a good list to me, Courtney. I don't know how the others feel, but and it's based on board input and the filtration system that we discussed in the meeting. So I would be good with that list that you have highlighted.
Okay, yeah, and somewhere along the line, Eliquis has fallen off the drill down list anyway, and it was only one member selected, but yeah, Shelley, I see your hand up.
I could be supportive of that. I mean, I don't think if Zeljans just makes the list because we dropped it down to 6, to me, 6 is getting pretty close to not representing half the payers. So I would not be for adding Zeljans because we limited our filter down to 6.
But on this one, Ziljans, it comes up because 3 board members are interested in reviewing it.
And while I hear that, I mean, I modified my own choices based on what we all agreed to today as our filter. So I don't think it's appropriate to grab what board members thought before this discussion, because I think during this discussion, we level set as a board what our filtering process was going to be. Maybe I'm hearing this wrong, but Vice Chair Dr. Hartung?
I think there was some back and forth around. I'm a little uncomfortable with the number of insurers reporting just because they're not weighted equally. Like each insurer might have a different number of patients and different size, and so it just and then so that kind of makes me a little uncomfortable just to setting like a threshold of insurers reporting, and that, you know, if we're ranking by, let's just say, net costs, we're de facto capturing the biggest impacts. And you know, they may have not have rated it in their top, but maybe they have a different segment of the population. And so I guess going back and forth on the number of insurers reporting it across any of the lists, I feel like it's, you know, maybe it shouldn't be set in stone as kind of firm criteria. But I hear what you're saying, in terms of representation.
I mean, I feel less strongly about that piece than I feel about kind of grabbing from how we originally looked at it to how we're looking at it now, because, you know, as a board, we've kind of went through how we want to filter it. But I definitely hear what you're saying, that some of these have way more volume than, you know, one carrier has a lot more volume than another carrier. I just didn't want to arbitrarily kind of add drugs because board members may have identified them before we together set our filtering for today. But Ms. Hoagland?
But it sounds to me like we're talking really about just whether we add Xeljanz or not. And with 10 drugs, that seems like a reasonable amount to, you know, move on to the insulin. That's my opinion.
Yeah, and hearing the conversation, you know, I do want to reiterate that the foundation of the drill down is still the same that happened last month and that the board members applied. The filters may have been applied a little bit differently, and the difference between this drill down and the rest of them is really just the removal of the carrier, right? And at this point right now, it's just the removal of also orphan products. So, but at any case, 3 board members did indicate through their drill downs of still applying the same structured methodology in some capacity that Xeljanz is a drug of interest to review. All the rest of it, and they all fall, like this right here is the overall list. So majority, and that's what I just, you know, highlighted here. Majority of the drugs, except for the Xeljanz, is on this list. So the board can decide to go with the highlighted and just go with the 9 and remove Xeljanz, or take a risk and utilize Xeljanz because 3 board members have indicated through some process of drill down independently of wanting to review it. And Chris, I see your hand up.
Do we need to make a motion, Courtney, to approve
Yep.
the subset list?
Yes.
So I'll make a motion to approve the yellow highlighted meds on the screen that Courtney is displaying for us right now to be those medications be the subset drug list that we used for 26.
Okay. Just for the record, I'm going to name those drugs out. So just for clarification, Chris made a motion to include Ocrevus, Tremfya, Skyrizi, Zollar, Keytruda, Verzenio, Valges, Jardiance, Manjaro, and Ozempic as the subset list for the review. Is there a second on the floor? Mr. Kennedy?
I will second that motion.
Thank you. I have a first and a second. Melissa, can you take a moment to call roll?
Lori Hoagland,
Yes.
Dan Kennedy,
Yes.
Michelle Coder,
Yes.
Chris Lehman,
Yes.
John Murray,
Yes. Yes.
Vice Chair Dan Hartung,
Yes.
Chair Shelley Bailey.
Yes.
All right. Congratulations. You got your 2026 review drugs. We will start getting the list ready.
Good
to
job,
send-
Courtney. You got us through it.
Couldn't do it without all of you, that's for sure. I'm going to take a moment and stop sharing my screen. I need to pull up the insulin list real quick, and hopefully we can do it. We may have to extend time just a little bit, but again, this one isn't as prevalent as the other one, and I'm sharing this whole spreadsheet, so I do apologize. It's a little bit overwhelming. Because really there's no drill down methodology that was applied to the insulin products. What we do have is here where board members were interested in the human RU500 and the RU500 quick pin. However, I'm happy to sit for a few moments. And Chair Bailey, did we want to extend time or just see how the conversation goes for the next 15 minutes?
I think let's see how the conversation goes based on the information you kind of just shared before that. So,
okay. So I'm going to lean into the board members since y'all kind of looked at insulin products in some capacity. If there's a drill down methodology, if the board just wants to go with the drugs that were reported by majority of the board members that went in. Yeah, Chair Bailey.
I mean, one filter that I applied when I was looking at this and, really trying to think of it was the end of year package price. That was and I get that units are not always apples to apples and packages are not apples to apples, but that was something that I used when I was looking at filtering. As well as I personally filtered out less than 100 enrollees.
Chair Bailey, do you know where you filtered out package price? Because I just
And I wrote it in my notes to myself.
I just see payer pay enrollee. Unless Heather, do you know where it's at quickly?
And part of why I was doing that, because I was keeping in mind that there was a lot of WAC changes that, and some of those WAC changes I think were also 2025, but that was one way I was trying to get at it. But no, right now looking at it, I don't see where exactly that column is. But I also don't think I made it up either.
Courtney, if you can go to the NDC level.
Okay, that's amazing. All right.
Okay.
And scroll to the right. Keep going.
Effect size measure.
I guess this showed I really
Just
dug
a
into
bit.
it, right? It's buried.
Yes, right there, column Y.
Okay. Gotcha. There it is. And you said you did it from largest to smallest, Jillian?
And so that's how I was doing that, and then I filtered out patient, like less than 100 enrollees. And that's how I personally got to my top one that I provided, which was Teamlin RU500 QuickPen.
Gotcha.
And I see that other members that also came up on other members' sheets as well. They may have filtered it a different way to come up with the same drug, but that was at least part of my thought process.
Gotcha. Nope, sorry, wrong one, wrong way.
But while Courtney's just kind of showing that, do any other board members have a perspective on how they came up with trying to look at insulin?
Hey, Michelle.
I used the same methodology that you used, Chair Bailey.
Well, again, because we're not under a specific number for insulin products, is there one or two, three drugs that are insulin products that the board would be interested in sending through the data call? Or just to collect information? Because according to that drill down from the WAC, you have 4. So Tanjuro, Maximum Solo Star, and Tanjuro Solo Star still have the same WAC price unit as the RU500 QuickPen. The concentrate has a WAC price of 74.35. So I'm not sure if the board's interested in collecting information on those 4 insulin products, or if there's another way to look at this. Yeah, John.
I would move that we study the top 3 on this list and move them forward for review.
Any other conversation or agreements? Support, not support? Yes, Dan, I see your hand up.
Oh, I have a question for John. John, is that partially at least based on the number of individuals on that medication? Because I noticed the Humulin and our U500 concentrate has significantly fewer individuals on it.
It had something to do with that, although it's the persistently high cost of the medication over time that is an issue for me, honestly.
Okay. Thank you.
All right, so yeah, Dr. Hartung.
I mean, we reviewed the Lantus products last cycle, so I don't know if we want to avoid those this cycle. We had problems with that Define one. Or the Glargine, sorry.
That's true. That's a decision for the board. If you're interested in going back to Tajiro Star products.
I'd be comfortable with doing one insulin.
I see lots of head shaking, so it looks like everybody's in somewhat of a nonverbal agreement for one insulin product. And is the board interested in reviewing both the QuickPen and the concentrate?
if we're gonna do that, I would suggest a minimum then the Toujeo Solostar, looking at the total number of claims. Right? And so could that be the Toujeo Max Solostar and the Toujeo Solostar? I'm just trying to look at the number of people. But again, that plan design, so maybe there's a higher rebate on those, you know.
I think what I was hearing was that the conversation was regarding Humulin RU500 and then the RU500 concentrate for review, since the Toujeo products were reviewed and the board determined that really there was no cost impact during the voting process. So Chris, I see your hand up.
Yeah, I agree with what you said, Courtney. And then in respect to John, I think he made a motion, so we probably need to either vote on that or make an adjustment, because I think he made a motion, right, to use the top three. Is that right, John?
Yeah, but it kind of died for lack of a second. So another motion could be made, Chris, I think. So
Yeah, I think it needs to be a clearer motion. And if a motion is made, just to ensure that it's indicated that those two are the products. So whenever our board member, these are the ones, but Dr. Hartman.
I move to add U500, the quick pen, and the concentrated solution to the subset list for affordability review.
All right, works for me. And I got a second, Mr.
I'll
Kennedy.
second that. Oh, sorry. I'll second that.
Thank you. Dan Hartung first made the motion. Dan Kennedy seconded. Melissa, can you please call the roll?
Lori Hoagland,
Yes.
Dan Kennedy,
Yes.
Michelle Coder,
Yes.
Chris Lehman,
Yes.
John Murray,
yes.
Vice Chair Dan Hartung,
Yes.
Chair Shelley Bailey.
Yes.
Motion passes unanimously.
All right, congratulations, board members. You have selected your subset lists. We will get these over to the carriers and process. Hopefully next month will be a little bit lighter, not too much focus on drug reviews. Great job today, and congratulations on getting that report finalized. I'll just make the quick update to the narrative under the recommendation, but lots of great work today. Appreciate working with you all. Have a great rest of the month, and I'll see you soon.
Thank you, Courtney. So I would like to announce the next board meeting date and time, which is Wednesday, April 15th, 2026 at 8 a.m. Pacific. And with there being no further business before the board, all in favor of adjourning this board meeting, please say yes.
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 Any opposed, please say no. All right, we will see everyone next month on April 15th, 2026 at 8 a.m.
Great. Thanks, everybody.
Thank you.